Topcliffe airfield as well. So I hope you'll give me some encouragement that we are going to be on track for a number of fast jets going forward.
We certainly will be purchasing a number of fast jets. The exact number will be obviously subject to debate, but we expect the F-35Bs, a number of them, to be purchased. And of course, in terms of the training of pilots, which the noble Baroness raised, the training and retention of pilots is something that the review that we've got, ongoing review that we've got within the Ministry of Defence, will need to look at and is looking at very carefully. But she's very right to raise that as an issue.
At least a bigger reason for the number of Royal Fleet or auxiliary ships stuck alongside is not the age of the vessels, but the absence of seafarers to staff them. Can the Noble Lord the Minister update the House on the ongoing industrial action as affects the Royal Fleet Auxiliary, which is obviously having a significant impact on the Royal Marines and the Royal Navy?
Noble Lord for raising the point about the industrial dispute that there is with respect to the Royal Fleet Auxiliary. The only thing that I can say to him is that discussions are ongoing with respect to that, and we obviously hope that that can be resolved to everyone's satisfaction in due course.
The statement says that difficult decisions are required. Should those difficult decisions, or at least difficult considerations, not be to give serious consideration to whether we should continue a nuclear weapons program? I note that Philip Stevens, a contributing editor to the Financial Times, wrote in a piece this week that the Defence Review, as currently constituted, is a necessary start but an inadequate one to considering our defence policy. Stevens says in that article, a brave government would ask whether it is wise to spend so many billions on a nuclear system maintained by the US. Is this a brave government?
It's certainly a brave government, but let me just say it's been a consistent policy of whatever government has been in power to support the nuclear deterrent. The nuclear deterrent will continue. We will renew the nuclear deterrent. And I just say to the noble Baroness, who's quite entitled to the opinion that she holds, I think it incumbent upon us to do that. I think when the threats that we're seeing from President Putin, the irresponsible threats at the present time, raise the whole prospects of it. But let's be clear about this. We support the nuclear deterrent and we support its renewal, and that's an important part of our defence.
Can I draw members' attention to my relevant register in the interest as a member of the TARLES Advisory Board? Can I offer some sympathy to the government regarding their defence inheritance, which must appear to be an appalling mismatch between requirements and resources? When I was in the MOD, when we needed to save money, it often had to be found where savings could be made, i.e. in money that was uncommitted, as opposed to where savings should be found, often on money that was committed, but on historic mistakes. Can I therefore ask the Minister if he can confirm that the process applied has been truly rigorous in respect of operational priorities? And can also, just within those priorities, you mentioned the deletion of Watchkeeper. Did its deletion recognise the potential associated sensitivities to defence export sales in the Middle East, including sensitivities that involve GCAP? And then my second question, if I might ask, the statement mentioned a fully fledged National Armaments Director. Can you just perhaps offer the House some insight into what is the defining element of this fully fledged National Armaments Director, and particularly what will define his relationship with the defence industrial primes? Will it be a relationship that does ensure going forward that defence capability is principally bought in the context of benefit to the taxpayer and defence as opposed to shareholders of defence industrial primes?
First of all, we did recognise the sensitivities around the deletion of Watchtower, and the sensitivities around that were a consideration. In terms of operations, of course, the decisions around the decommissioning that were made were made in a way which would not compromise the operations, and the chiefs were clear to us that operations would not be compromised by any of the decommissioning that was taking place. Can I say on the part of the the point around National Armaments Director, which I think is an extremely important point. The whole question of the National Armaments Director is to give greater strength, if you like, to the idea that we need to rebuild our armaments industry and to ensure that the stockpiles we have are of sufficient size for us to meet the threats of the future. And in doing that, the relationship with the defence industry, whether the primes or indeed whether the smaller companies, will be important. And I think the important point is it's not to be something that's in the interest of the shareholders, but is actually something that we need to discuss, which is in the national interest and in the interest of our international alliances. And that's what's important for us all. We have to have an armaments director which drives forward an arms industry which gives us the weapons and the stockpiles that we need. And just in answer to Baroness Smith's point, I haven't seen the article with respect to the Financial Times and the European Defence Industrial Strategy, but that's certainly something we've been discussing with European friends.
Noble Lord the Minister, in concluding his remarks, pointed to the need to be prepared for future threats. And the United Kingdom has extensive infrastructure within the contiguous exclusive economic zone around these islands, be that the oil and gas pipelines, be it the gas and electricity interconnectors, be it in fact also the vital undersea cables that are so important for the city, and the 2/3 of financial services and professional business activity conducted outside London. So really, Britain's leading industry, very vulnerable. In view of the events last week in the Baltic, and the fact that there are 3 warships now around this possibly offending Chinese vessel down off the Skagerrak, and the continuing grey zone activity of Russian vessels around our coasts and this vital infrastructure, is the Minister content that we have this infrastructure adequately protected for our future and for today?
I think that's one of the questions the Defence Review is actually looking at as well, that how do we protect underwater cables, etc., and pipelines. And certainly that is one of the things that the Defence Review will consider, and we're certainly considering as well the capability that we've got to deal with that. I hope I can reassure the Noble Lord that actually I was in Copenhagen last week, where with the northern group of states, we actually discussed what more we could do together to protect underwater cables and to work together. And indeed, without going into too much detail, there have been a number of operations that we've conducted together to try to protect and deter with respect to these particular cables, etc. He will also know that there have been other activity across the world where we've also sought to defend those cables from those who would do us harm and undermine the ability of our industry and others to operate in the way that they should be able to.
Second reading of the Mental Health Bill, the Baroness Merron. Might be best if we have a short pause to let people leave if they wish.
My Lords, I beg to move that this bill be now read a second time. My Lords, it is an honour to move the second reading of the Mental Health Bill, a bill which members of both houses have been waiting for and working on for some considerable time. There is much consensus that our mental health laws are not fit for the 21st century. Many elements of the 1983 Mental Health Act are outdated. Its operation is associated with racial disparities, poor care for people with a learning disability and autistic people, and it fails to give patients an adequate voice. Modernising the Mental Health Act is a vital manifesto commitment for this government, and so I'm proud to be introducing reforms to ensure that care is appropriate, compassionate and effective, that gives patients more say over their care, that will improve support to help patients understand and exercise their rights, and to protect the safety of the public, staff and patients. The wait has been too long, my lords. I know that a number of noble lords were involved when the Act was last amended substantially in 2007. But while attitudes to mental health have thankfully changed since then, the law has not kept up. This bill is the product of the combined effort over some years by members of both houses and of many outside of Parliament, which all parties have rightly come together to support. Sincere thanks are due to many, and to highlight just a few, let me start with members of your Lordship's House who served on the Pre-Legislative Scrutiny Committee in 2022. The Noble Lady Baroness Buscombe as Chair, Noble Ladies Baroness Barker, Baroness Berridge, Baroness Hollins and Baroness Mackintosh of Hudnall, and the Noble Lord, Lord Bradley. All have given a huge amount of time, expertise and energy which has informed and motivated this government to strengthen the bill. And I can confirm that we have improved the previous draft bill by heeding the committee's recommendations to include guiding principles and advanced choice documents in this revised bill. I also want to pay tribute to former Prime Minister, the Noble Lady Baroness May, with whom I had the pleasure of meeting earlier today with the Secretary of State. Baroness May identified the need for modernisation and set up the independent review of the Act in 2017. And without this, we would not be here today. And to the Independent Review Chair, Sir Simon Wesley, and his Vice Chairs, including the Noble Lady Baroness Neuberger, who made the case for change, provided the blueprint to follow, and I know will continue to be champions for reform. Thank you. I also thank the many stakeholders and parliamentarians that have engaged with us ahead of second reading and over the years, and also those with lived experience who have bravely told their stories. My lords, the bill will complement other major reforms that this government has announced. The budget announced £26 million to be invested in new mental health crisis centres to reduce pressure on accident and emergency departments. To cut mental health waiting lists, we will go further still, recruiting an additional 8,500 staff. As part of our mission to reduce the lives lost to suicide, these NHS workers will be specially trained to support people at risk. And we will improve support for young people with walk-in hubs in every community, making support workers more accessible to children and a specialist mental health professional based in every school. The NHS has also asked every provider of mental health services to review their offer for serious mental illness. And by focusing on early intervention, and prevention is the key, we seek to prevent people reaching crisis and reduce the need for detentions in the first place. My lords, I now want to turn to what the bill seeks to achieve. The Mental Health Act is there to protect people. Its core purpose is and will remain to be able to intervene, to detain and to treat when someone is so unwell that they present a risk to themselves or others. The overall aims of these reforms are to improve the care and treatment of people with severe mental illnesses when detained under the Act, to improve patient outcomes and recovery, and to protect public, patient and staff. The existing Act confers certain rights on people who are detained, including the right to appeal their detention at a tribunal, a right to an advocate, as well as to a medical second opinion in certain circumstances. And this bill seeks to strengthen and expand these rights. It will require the inclusion of the new and revised guided principles recommended by the independent review in the Statutory Code of Practice, which in turn informs professional practice around the Act. By doing this, we aim to improve things for patients and support a change in culture. We are strengthening and clarifying the detention criteria to make clear that people will only be detained if they pose a risk of serious harm to themselves and/or to others. And if there is a reasonable prospect, they will benefit from the proposed treatment. We are reforming the use of community treatment orders, or CTOs, to reflect the revised criteria, to increase oversight and scrutiny of decision-making, and to improve the transfer of patients under a CTO from hospital to community services. We are also introducing statutory care and treatment plans for patients detained under the Act, except when under very short-term sections, to provide a clear plan for a patient's recovery and a path to discharge. And my Lords, where the patient's voice has previously been unheard, this bill will place them at the centre of their care and treatment. We are introducing a new clinical checklist requiring clinicians to, as far as is possible, involve patients in decisions about their care and to take their feelings and wishes into account. We are making sure that patients know that they can create an advanced choice document and that appropriate support is available to help them do so, allowing those at risk of detention under the Act to outline their wishes and decisions whilst they are well. This document helps them retain control over decisions about their admission, their care and their treatment if they later become too unwell to communicate these preferences. And I saw and heard about the differences that these can make on my visit to South London and Maudsley last week, where the words of welcome from service users from this measures particularly highlighted the contribution that advanced choice documents can make to tackle racial inequalities. And my Lords, we are allowing patients to choose a nominated person to look out for them and their interests when detained, and will be increasing their powers. My Lords, the Independent Mental Health Advocacy Service was a notable success of the 2007 reforms to the Act. It is a thriving sector, with advocates and volunteers working for excellent organisations such as Voiceability, making sure that people are involved with decisions about their care. We are now looking to expand these services in two ways. Firstly, by making sure that patients who come into hospital voluntarily can access an advocate to help them understand their rights and be involved in decisions about their care. And secondly, for detained patients, access to advocacy will be on an opt-out basis, ensuring that patients are proactively offered this support when detained to improve advocacy uptake amongst detained patients. I know only too well that noble Lords are acutely aware that for some people with a learning disability and autistic people, detention is both non-therapeutic and unnecessarily long. So in order to better meet people's needs in the community, we will limit detention so that people with a learning disability and autistic people can no longer be detained beyond 28 days unless they have a co-occurring mental health condition that requires hospital treatment. This will only affect civil patients. Hospital will remain an option for those in contact with the criminal justice system, where the only alternative to detention in prison in hospital is prison. And for people with a learning disability and autistic people, the right measures and support are very much needed alongside this change, which is why the Act will require that when detained, there is a care, education and treatment review to be given due weight in decision making. And we're creating new duties on commissioners to hold registers to help manage the risk of people going into crisis and being detained, and to better meet the needs of people through appropriate community services. My Lords, I am grateful to the work of the Ministry of Justice Minister, my noble friend Lord Timpson, and his department to improve access to mental care and treatment for people in the criminal justice system. The bill will end the use of both prison and police cells as places of safety. It will end the use of remand for own protection under the Bail Act, where the court's sole concern is the defendant's mental health. And we will introduce a statutory 28-day time limit for transfers from prison and other places of detention to hospital when a person requires treatment for their mental health under the Act. We will also introduce a subset of conditional discharge called supervised discharge to support the small number of restricted patients who are no longer benefiting from being in hospital. My Lords, we are aware that there have been concerns about public safety, and therefore ensuring that our reforms do not weaken the ability to detain people who could pose a risk of serious harm to themselves or others. I can assure your Lordship's House that these reforms do not change the core function of the Mental Health Act. Clinicians will remain able to intervene, to detain and to treat whenever someone with severe mental illness presents a risk to themselves or others. My Lords, we are confident that this is the right package of reforms. However, this bill further strengthens the measures in respect of public protection, and the bill improves on the previous draft bill by firstly accepting the Joint Committee's recommendations to remove how soon from the new detention criteria, making sure that the Act cannot be misinterpreted to mean that a harm must be imminent to justify detention and early intervention. Secondly, by introducing a new requirement for the responsible clinician to consult another person when they are making a decision about whether to discharge a patient. And thirdly, by strengthening the Code of Practice's guidance on discharging patients and promoting the need for discharge planning tailored to the individual needs of patients and their circumstances. And we will be consulting on changes to the code. I am very grateful to noble lords across the House for their ongoing support and interest in this bill. It has been a long time coming, and I know that we all want to get this on the statute books, which is why it is a priority piece of legislation for this government. There has been a failure to reform, but today we begin to change that. And I look forward to what I know will be a collegiate and constructive debate, which many will follow, both inside both houses and also outside. My Lords, I beg to move.
The question is that this bill be now read a second time.
My Lords, let me begin by extending my gratitude to the noble Baroness Lady Merrim for introducing this bill into your Lordship's House and for her very clear exposition of its contents. It is a bill which we on these benches warmly welcome. That welcome shouldn't come as a surprise because, as the noble Baroness has said, the bill before us is the successor to a draft bill prepared by the previous government, a draft which itself owed its origin to my noble friend Lady May, under whose watch a review of the 1983 Act was initiated some 7 years ago during her time as Prime Minister. Much of what we see laid out here is the product of diligent work carried out by Professor Sir Simon Westley and his review committee, as well as the joint committee of both houses, so ably chaired by my noble friend Lady Buscombe. So, my lords, the passage of this bill presents us with a golden opportunity to address both the current state of mental health provision and the law that governs it. The last major update of the Act took place in 2007 under the previous Labour government. That may not sound like a long time ago, but as we shall no doubt hear from others, experience gained in the intervening years has taught us that a further update is indeed warranted if we're to ensure that the Act remains relevant and appropriate and that its powers are proportionate. Wherever the state uses its powers to deprive an individual of their liberty, the necessary safeguards must be in place so that those powers are used sparingly, proportionately, and with the highest regard for human dignity and autonomy. That is why this bill is so important. Since the last set of changes to mental health legislation in 2007, the number of people being detained under the Mental Health Act has grown exponentially. In fact, since 1983, the numbers have nearly doubled to a total of over 52,000 new recorded detentions between 2023 and 2024. But within that total, we've also seen a stark disparity in the classifications of those being detained. Black people are 3.5 times more likely to face detention under the Act. And shockingly, to my mind, there are currently over 2,000 people with autism and learning disabilities detained in mental health hospitals across the country. I was equally shocked by the realization that people with autism can be detained even if they do not have a mental health condition, leading to disproportionate, burdensome and wholly inappropriate treatment. These issues occupied centre stage in the Wesley Review, which proposed the formal recognition of 4 key principles that should from now on govern both theory and practice in this area of the law. The principles are choice and autonomy, least restriction on liberty, therapeutic benefit, and the person as an individual. The previous government fully accepted these 4 principles, and giving life, as it were, to those principles, the draft bill set out to make a number of important changes. It strengthened the rights of patients with a learning disability. It gave patients greater autonomy in choosing how they wished to be treated. It introduced duties on commissioners to better understand and support people with a learning disability or autism who may be at risk of crisis. And it sought to update community treatment orders, which are one of the key drivers of racial disparities in the numbers of people subject to restrictions under the Act. It's therefore very pleasing indeed to see this government's firm commitment to enacting exactly these reforms. And I, for one, hope that as the bill proceeds, we can come together as a House to implement and, where necessary, improve this hugely beneficial set of changes. My Lords, with consensus as the thread that happily we expect to run through our consideration of this bill, there are nevertheless certain themes within it that are likely to require our particular attention. The first of these is community treatment orders. CTOs were first introduced in the Mental Health Act of 2007. The Joint Committee on the earlier draft bill were very clear that CTOs have been widely overused and that they're one of the leading causes for the racial disparities that I referred to a minute ago. The bill before us makes a number of changes to the criteria governing the use of CTOs, all of them designed to support 2 of the key principles in the bill, those of least restriction and therapeutic benefit. As far as they go, these changes are desirable. However, the bill stops short of including the full suite of recommendations made by the Wesley Review. The Centre for Medical Health has raised this as a key concern. They point out that there's still no persuasive evidence of the benefits of CTOs. And against that background, They argue that a number of checks and balances are needed to the use of CTOs in the future, over and above those already in the bill. In particular, they note that the committee recommended a full statutory review of the use of CTOs to report within a fixed timeline, which, on the face of it, is the least that we should be doing. I think we'll want to debate in committee why the government has not felt it appropriate to go as far as the Joint Committee and the Independent Review recommended in this area. The next important theme, to my mind, is that of children and young people. According to NHS data, and as highlighted by Lord Darcy in his recent review, in 2023-24, 932 children in mental health units were subject to restrictive interventions. In total, more than 84,000 restrictive interventions were carried out on these children, which is a 51% increase from the year before. This is the highest number of restrictive interventions recorded since figures were made available in 2019. And that is despite the number of children in mental health units appearing to decrease. My Lords, I think we have a duty to use this bill as an opportunity to identify ways of reducing such restrictive interventions and using them more humanely and more proportionately. 2 years ago, the government launched the Oliver McGowan training for NHS staff to help them better deal with young patients with autism. As noble lords may remember, this was in response to a truly harrowing and appalling set of occurrences that ended with the death of a young man. It's fair to say that the case shook the health service to its core. And I believe we have in this bill the opportunity to take forward those lessons so as to protect children who may be at risk from unwarranted detentions. Both the Independent Review and the Joint Committee had much to say about the treatment of children under the Mental Health Act, how that could be improved. Unfortunately, by no means all of those recommendations have found their way into the bill. One such omission relates to the inappropriate placement of under-18s into adult wards or into facilities which can sometimes be miles away from their home. The Joint Committee found that in each of the years 2016-17, 2017-18, 2018-19, over 1,000 children were placed out of area, and that in 2020, 21% of children and young people were placed as inpatients more than 50 miles from their home. It's perfectly obvious that being taken to an unfamiliar environment in a place far away from friends and family is almost guaranteed to exacerbate the issues young people face when experiencing a mental health crisis. On top of this, data from the Care Quality Commission showed that in 2021, 249 children and young people admitted for mental health treatments were housed on adult wards for more than 48 hours, some for a good deal longer than that. These are uncomfortable figures, and I hope noble lords on all sides of the House will want to ensure that through this bill we take all possible steps to bear down on the scale of these problems, to strengthen the protections afforded to children and young people. My lords, one of the core themes that has remained prominent throughout the process that has led to this bill is that of choice, giving patients as great a degree of autonomy as possible in how they're treated and maximising their ability to determine what happens to them if they are detained. In that regard, I think the bill succeeds on many counts, but one measure recommended by the Joint Committee was that there should be a statutory right to an advanced care document for every patient who has been or may be detained under the Mental Health Act. The bill as it stands doesn't follow up on this recommendation. Instead, it places a duty on NHS England and integrated care boards to make information regarding such documents available to patients. Now, I don't doubt that this is a beneficial reform, but I think we should debate whether it goes quite as far as it usefully might. Guaranteeing patients and service users the chance to state and record their preferences for care and treatment plays directly into the key principles of choice, autonomy, and treating every person as a rounded individual. So what are the barriers to doing that? My Lords, there's a whole host of detailed issues that we need to cover in committee, but the final major area that I want to touch on is that of the role played by the police. Inevitably, there are circumstances that arise in which the police are required to become involved with people who may be at risk to themselves or to others, but there is a strong feeling that encounters with the police are far too common for people with mental health conditions. As the independent review, and indeed the National Police Chiefs Council, have pointed out, the presence of the police in situations where a mental health issue poses a risk of serious injury or death can be counterproductive. The Metropolitan Police, in their written submission to the Joint Committee, stated that, quote, our officers simply cannot provide the specialist care needed, exposing both patients and officers to extreme risks. The NPCC has also expressed their concern that the role of police in mental health pathways must be reduced. It is welcome then that the bill goes some way to addressing this. Section 46 removes police stations and prisons as places of safety, thereby preventing patients experiencing mental health crises from being locked up inappropriately. However, there is a potential knock-on effect from this that I think we should talk about in committee. Well-intentioned as the provision is, it could well lead to a rise in people being admitted to accident and emergency departments escorted by the police and having to wait in crowded spaces with a lack of the necessary specialised facilities until they can be assessed by clinicians. Now, in that environment, the risk of harm could well be multiplied. I do think we need to ask how that risk can best be mitigated. I fear that any realistic answer will need to involve resources, by which I mean taking steps to ensure that the requisite arrangements are made for NHS trusts to deal with an increase in the number of mental health patients being admitted to hospitals as places of safety. Not an easy set of issues, but it's a subject we can't duck. My Lords, Parliament must see to it that wrongful, inappropriate and untherapeutic detentions of those undergoing a mental health crisis are brought to an end. This bill provides us with a necessary and welcome opportunity to transform the treatment of those with mental health conditions and to bring both doctrine and practice well and truly into the 21st century. Along with my noble friend, Lord Kamal, I look forward to working with the Minister and with noble lords on all sides of the House to scrutinise and where we can, improve the bill's provisions. Many thousands of the most vulnerable members of our society are depending on us to do so.
My Lords, I declare an interest as a member of an advisory panel for Rethink Mental Illness. My Lords, the House of Lords is an institution which is frequently criticised. And those of us who are often called upon, not least by school children, to defend the House of Lords, often find ourselves having to give examples of work that would be done by the House of Lords that wouldn't be done by anybody else. And I have to say, my Lords, as a veteran of the pre-legislative scrutiny of the Mental Capacity Act, the post-legislative scrutiny of the Mental Capacity Act, the pre-legislative scrutiny of the 2007 Mental Health Act, and all of the various bits of subsequent legislation. I think we've now arrived at a point with this piece of legislation where we can make a defensible case for the unique contribution of this place to legislative progress, because, as the Noble Baroness Merrin was generous enough to say in her introduction, there's a lot of us who've got form on this in this place, and specifically there are an awful lot of us who have a lot of detailed knowledge of all of those bits of legislation and indeed the workings of the 83 Act. It's therefore, she won't mind me saying, that we come to these pieces of work that we have to do with in two minds. I mean, one, it's great to have the opportunity to go back and look at what we did in the past and rectify some of the mistakes. But it's always also deeply frustrating because, in truth, here we are again, patching up the 1983 legislation, putting another patch on it. And we will never, ever get the mental health system that we so badly and desperately need until we do that. Having said that, I have, like everybody else, I have want to congratulate Sir Simon Wesley and his team, and specifically the working groups who worked with him. And I would say to any noble lord who's been inundated with briefings, as we all have been from all the interested parties, if you're ever in doubt about a subject, go back to the reports of the working groups of that report, and you will understand, I think, how that people have arrived at their conclusions and what perhaps we should be striving for. And I say that as somebody who, I'm the person who sat here night after night during the passage of the 2007 legislation, arguing for advanced choice documents against a lot of entrenched opposition to it, not least from practitioners. And it's really important that we use the privilege, and I do mean the privilege of our position, to work away at this legislation like that, because it's perhaps uniquely we can get to make some progress. For myself and for those of us on these benches, we will support anything which makes clinicians have to be more accountable and transparent in their work, because we can have any legislation that we like, but until such time as we call decision makers to account, we're not going to get anywhere on behalf of people who are detained. And we lose sight. They may be detained for their own good. They may be detained for the safety of they are nonetheless detained, and their capacity or their opportunity to challenge those decisions that are made are quite rare. And always, as ever, I think in this House we have a duty, in the end, when we're coming to a decision, to defend human rights. Human rights legislation exists to defend the people that nobody in society likes, and quite often that means the people who are subject to this legislation. Having said all of that, on the issue of principles against the bill, this will surprise Baroness Merrin not a lot. Having gone through the Mental Capacity Act, having then subsequently reviewed it, its implementation, and had serried ranks of professionals come in and tell us that they just ignored the principles which have been on the face of that bill since the beginning. I have to say, not overjoyed that they're going to be stuck into a code of conduct. I don't honestly think it will make any difference at all. They are very good principles, but unless and until they are on the face of the bill and practitioners believe that their decisions will be judged against them, then they're going to be useless. On learning disabilities, there are lots of other people who can speak about that matter far better than I can. I simply want to say two things. First of all, Noble Lord Earl Howe talked a bit about training of professionals in relation to young people. Well, increasingly people are being diagnosed with learning difficulties and particularly autism as older adults. I think that one thing that we should do, we should listen to the things that Baroness Hollins has been telling us for years, and we should require all mental health practitioners to have training in the diagnosis of learning disability and autism. That's the one thing that would make a swift and tangible difference in this area. Second thing I would say is the alignment of non-alignment of the Mental Capacity Act and the Mental Health Act is something that has been problematic, and we have known about that for more than 20 years. To everybody who knows about it, I will simply say the words Bournemouth Gap. To those who don't, I would simply say we have two pieces of legislation which are built on completely different basis, and a person or two people sitting side by side can be treated either by one or the other, depending on who's in the room at the time. And what matters is that if you get banged up under one, you have quite a lot of rights, and if you get banged up under another, you don't. And I understand why Sir Simon and his team thought that it would be too long and too difficult a job, and it was much better that we carry on and do some of the more urgent things which are in this bill. But we have to go back and sort that out. Other jurisdictions are going down that path. And the one thing that I think the Baronet, Noble Baroness and the government have to do is give a commitment that they will monitor that, and that they will, upon the passage of this bill, put in place a system of research, funded research, about the change to bring in what is known as fusion legislation. Because if we don't, we're just going to consign a load of people to being wrongfully treated. So I do hope that she will do that. In a similar vein, Dr. Lucy Series and Luke Clements, who are academics and practitioners who've worked a long time on this, sent us a briefing that explains in characteristic detail the deficiencies that have come under Section 73 of the Care Act of 2014. What it means is that people who are being treated in private settings, even though their treatment was commissioned by the NHS, are not being properly protected by the Human Rights Act. They've written to us a very short but very effective paper, and I would simply ask the Noble Baroness, would she commit to a meeting of interested peers, because there are a number of interested peers, with Dr. Series and and Luke Clements, so that we can deal with that and just stop treating people differently just because of the person or the organisation which happens to be providing the care to them. On CTOs, we're not allowed to wear T-shirts in here, but if we were, I was sorely tempted to say, told you so, because we did. In 2006 and 7, we sat here night after night saying, you're telling us that it's not going to be used very often, and they're not going to be used disproportionately against some people. Well, that's not true, is it? Well, it wasn't. It really wasn't. Because of that, I and a number of other, and particularly because of the racial disparities, I and other people were for a long time of the view that they really just should go. This was about enabling bad practice by practitioners. I have to say the thing which changed my mind was listening to patients and their families. There are a small group of people for whom CTOs work, for whom they are the least restrictive option and for whom they are beneficial. We therefore should keep them. I'm reluctant to agree, but we should. But we really do have to change all the processes around them to make sure that practitioners are sticking to the intention that was meant. On advanced choice documents, again, another choice, I told you so. I am so pleased that they have done what enlightened practitioners said to us back in 2005 and 6. They have improved care for people. I am indebted to Baroness Finlay for telling the Joint Commission, the Joint Scrutiny Committee about the work that was done in the field of palliative care to make sure that advanced choice documents are electronic and therefore more widely available, and to minimise the excuse on the parts of practitioners. Well, I didn't know about it. So I think there's a team from UCL, or is it QCL or King's, that has been looking at that. I really do hope that we will be able, in the course of our discussions, to go into that in greater depth about quite how that will work, because it will be important. On prisons and police stations, we were on the Joint Committee. We were very lucky. One of our members was an A&E doctor, so we talked about this quite a lot. And you know, the truth is, people will still turn up in A&E because the lights are on. That's where people who are in distress will go. There will also be people who are faced with somebody who is having an episode who will still call the police because they're frightened and they don't know what to do. And therefore, I hope in the course of this, I will explain why £26 million is going to deal with what is quite a big problem. But I hope that we will look at the transition between the police stepping back and leaving everybody else to deal with people who, at the point they meet them, are very ill and very disturbed and who need help. Final thing, my lords, some of us argued strongly for a mental health commissioner. Not because we want another commissioner, we've got lots of commissioners for things already, but really we were trying to deal with a key issue. We don't have a system of mental health care. We don't have joined up services. We have episodes of care, some of which are very good at the time, but they really don't work together as a system. And what we have never known through all the hours that we have sat in this place and looked at the various different bits of legislation in great detail, what we don't understand is why do we end up locking up more people year on year, and what's the best use of the resources that are available, which are not infinite, to not only deal with people who are experiencing real episodes of crisis and trauma, but ensuring that we use the best of what we've got to put as much as we can into services which are also preventative. My lords, it is a great privilege to be in this House. It's an enormous relief that we can do our work in great detail and largely away from the pressure of headlines, which I know people in the other place always feel whenever there is a failure. And it may well be that during the passage of our bill there'll be something in the media which will change the national mood in this. It's our job, our privilege and our responsibility to think of the people who are in the worst possible place under this legislation and to do the best possible job that we could do for them to make sure that we get the best out of this piece of legislation.
My Lords, it's a pleasure to follow the previous three speakers, and I declare my interests as a member of the NHS board as a non-executive director and 45 years as a registered mental health nurse. I warmly welcome the long overdue reform of the Mental Health Act and congratulate the new government on bringing it swiftly in their term. I appreciate the opportunity the noble lady the Minister has taken in holding discussions about the bill prior to this reading and her offer to consult further about potential amendments to strengthen and clarify particular sections. Modernising the 1983 legislation provides a real opportunity to reduce injustices in implementation and provide equitable support for people suffering from a mental health crisis, giving them more autonomy and choice and including the new right for service users to choose a nominated person to advocate for their interests. Firstly, I'm pleased that this bill aims to end the unnecessary detention of those with autism or learning disabilities, yet I can share the concerns of the Royal College of Psychiatrists and other professional bodies that further clarity is needed around assessment and treatment. For many, the proposed 28-day limit for assessment may not be long enough to reach comprehensive diagnosis, especially considering those with autism often present with additional complexities. It may be difficult to admit, assess and support some patients within the time limit outlined in the Act, risking recurrent use of overstretched A&E or admission and detention under Part 3 of the Act, should there be safety concerns. The NHS Confederation has drawn on the example of New Zealand, where similar changes made to mental health legislation saw an increase temporarily in patients being sent to prison, left neglected in the community, or admitted to forensic facilities as secure patients. Failing to allow for thorough assessment may worsen mental health care provision and further racial inequalities, as Part 3 detentions currently disproportionately affect black men. To combat this, an emphasis on continuity of community care would cut the number of people admitted for an assessment, while also ensuring patients remain safe within the community. Yet there is a chronic lack of community-based workers, with a third of all nursing vacancies being in mental health services. I therefore ask the government to provide clarity as to how they will ensure that those who in the past would have been detained for assessment and treatment will still be able to obtain a full diagnosis and the support they deserve, preferably without any hospital admission. Careful consideration with regard to workforce planning in the community for social work, allied health professions, as well as psychiatrists, general practitioners and nurses, should form a significant part of preparation for this bill's implementation. Then patients and carers could more often be appropriately assessed, treated and cared for by both mental and physical health services in community and primary care settings, thus avoiding admission. This bill offers an opportunity to improve support for those under the age of 18 who are admitted formally under the Act. Yet it is estimated that 31% of under 18s are, thank goodness, admitted informally to hospital for assessment and treatment. I fully support the introduction of new statutory care and treatment plans, but ask the noble lady the Minister, could these be extended to those admitted informally if it is a correct solution? The government is right to state that these plans will encourage patients to engage with treatments towards their discharge and beyond. Care and treatment early in a person's life provides better outcomes than later intervention, so extending these plans to the significant number of informal patients under 18 could provide a solid foundation for later life. Additionally, ensuring the availability of quality community services would also reduce childhood detention. I therefore ask the government to confirm its plans to encourage this early intervention via both the community and care and treatment plans. This bill would be strengthened if it were to improve the environment for young patients. I will not repeat what has so ably been explained by the noble Lord Howe on this issue. However, we really ought to move to a statutory requirement that young people are not allowed to be kept in adult wards for treatment in crisis or miles from home. There must also be an exploration of the place of parental responsibility before the bill is finalised. The introduction of a nominated person as well as an advanced choice documents are commendable steps to improve agency for those detained under the Mental Health Act. Some young people will choose not to include their parents for either of these. I therefore ask if the government can provide clarity as to how this will function with expectations of parental responsibility. Healthcare professional bodies support the principle of ensuring prisoners with severe mental health conditions are swiftly transferred to hospitals where they can receive proper treatment. But I do have questions of practicality of the government. What is the plan to ensure there is capacity in the inpatient sector? What happens to those for whom it is clear they cannot be properly treated in an inpatient sector or are a significant danger to others on the ward? As a formal ward sister, this is a real question from people working in those environments at the moment. Will there be an assessment at the end of patients' treatment to determine whether they are recalled to prison or given a community treatment order if safe to do so and better for their mental health? I would welcome working with the government for clarity on this issue, particularly in relation to a code of practice. Finally, as I have already raised, continuity and care in the community will be essential to prevent unnecessary detentions and provide support to patients after their detentions. I therefore ask the government for clarification on the implementation timetable for this bill to ensure current staff have time to receive the development needed and the necessary new staff are recruited. I also ask whether there should be a research investigation into safe staffing ratios in the community. The Royal College of Nursing calls for a maximum caseload for mental health community nurses to ensure that the community treatment orders are conducted properly and that nurses can assist in preventing crises occurring. But very little research has been done into this ratio issue outside inpatient facilities. It seems right that research and planning is done to ensure the community can help fulfil the admirable aims of this bill. There's a recent paper from King's College which talks about frugal innovation in healthcare. I would suggest that investing properly in community care will reduce the costs overall. I trust the potential shortcomings of the bill as it currently stands can be amended and or resolved through the Code of Conduct to ensure that it is future-proofed and significantly enhances mental health service provision for the patients, which is the aim of both His Majesty's Government, the vast majority of members of this House and healthcare professionals themselves.
My Lords, I'm grateful to be able to participate in the second reading of this important bill, and it's a privilege to follow the noble ladies Baroness Barker and Baroness Watkins, who have a real breadth of experience in this field. I too, along with many of the Lords here, welcome the reform of the Mental Health Act, which is long overdue. The noble Lord Earl highlighted the over-representation of minoritised communities detained under the Act, but also placed on community treatment orders. Some groups are also more likely to be detained through the contact with the criminal justice system or emergency departments. And it's important to remember that we are speaking about this inequalities in the wider context of health inequalities, in which some groups present far later to health services when their symptoms have worsened. The Royal College of Nursing note in their briefing that mental health services aren't seen as accessible to all communities, and that many black men have their first interaction with a service via the police during a crisis. Many organisations who have helpfully sent briefings ahead of the debate have acknowledged that the legislative actions available to address this are in fact limited. I know that the noble Baroness, the Minister, highlighted the advanced choice directives, which are a welcome step towards this. As the Joint Committee on the Draft Mental Health Bill notes, this is important for those who have experienced trauma, disempowerment and discrimination. Data collection has also been discussed in the scrutiny of this bill. Although data collection is improving, when we're looking at health inequalities in this way, capturing more complex data on ethnicity is important. In much of the work that I have done around health inequalities with the NHS and faith groups, ethno-religious identity is significant for communities to better understand at an ICB or higher level in understanding how to reduce inequalities. It is also important that in evaluating the changes to this Act, that the Secretary of State has to have appropriate data to do that. Could I ask the noble lady, the Minister, what steps the government are taking in this bill or in other ways to mandate this kind of data collection so that racial inequalities are monitored? The Royal College of Speech and Language Therapists also emphasised the consideration about communication being important to the bill. In my experience, some faith communities find it very hard to discuss mental health, and that is made worse by the biases and discrimination that they meet when they seek help. The Patient and Carer Race Equality Framework is to be welcomed as the first ever anti-racism framework for mental health trusts and service providers. The Royal College of Nursing has recommended that mandatory training be given to all working under the Mental Health Act on equalities to assist this. As I often say in this place, faith literacy is an important, essential component of that. Much of this is still about trust and culturally competent care. It is critical that services can be accessible and effective for people with different traditions, different cultures and different faiths. On the data point, empowering patients to offer their data is as important as mandating that it is collected. Many briefings also note that this bill will only be effective in reducing racial discrimination and health inequalities if there is investment in community services and other actions. Not everything we can and should do is medical. Involvement of the voluntary and community sector is also crucial. Turning, as has already been mentioned, to the treatment of those with autism and learning disabilities, I welcome the provisions in the bill to restrict the long-term detention of autistic people and those with learning disabilities. I support the recommendation from the Joint Committee on the draft bill for clearer duties for ICBs and local authorities to develop robust community services and social support. And I would like to pay tribute to the work of the Noble Lady Baroness Hollins and the Independent Care and Treatment Review Programme to expose the serious harm and trauma inflicted by the use of solitary confinement, detention and long-term segregation in mental health and specialist learning disabilities. And I too support the comments made by the Noble Lord Earl with regard to young people. The Right Reverend Prelate, the Bishop of Gloucester, is the lead bishop on prisons for the Church of England, and she apologises for not being in this place. But she and I commend the government for bringing forward the long overdue provisions to end the use of prisons and police cells as a place of safety. The noble, the prelate, the Bishop of Gloucester, has told me that over 300 people last year suffering mental health crisis were taken not to a hospital but to a police station. According to the recent report from the Chief Inspector of Prisons, the average time to wait to transfer mentally ill patients from prisons to hospitals is 85 days, almost 3 months. So we welcome the statutory time limit of 28 days, but also I highlight, along with other noble lords, that if this actually is going to happen, it needs to be resourced. Not just this point, but for much of the bill, there is a question of resource, as highlighted by the noble lady Baroness Watkins. Shortages of mental health nurses and doctors impact on those detained under the Mental Health Act and in the community. The learning disability nursing workforce in the NHS has dropped by 44% since records began in 2009. Investment in the workforce will be key to the success of this bill. Community services can only be developed and resourced as far as the NHS, local authorities, directors of adult social care are supported to do so. I welcome this bill and I look forward to following its passage and working on what is an extremely important reform.
My Lords, I refer the House to my interests as a Vice President of the National Autistic Society, a role I share with my good and dear friend and noble friend Baroness Browning. My Lords, I welcome the bill. It's been a long time coming, and I passionately hope that it will allow us to end once and for all the myth that autism is a mental health condition. Autism is most definitely not a mental health condition, and our failure to address this has meant decades when autistic people have been wrongly incarcerated, often in appalling and degrading conditions, robbing them of their human rights. More than 2,000 autistic people and people with learning disability and mental health are in mental health hospitals in England, point made by the noble Lord Earl Howe in his opening remarks. The National Autistic Society tells us that 68% of these people are autistic. And 93% of autistic people and people with a learning disability in mental health hospitals are detained, under the Mental Health Act 1983. The average length of stay is 5 years, but for a great number of autistic people, the detention lasts for decades. Professor Sir Simon Wesley's review of the Mental Health Act 2018 found that the experience of detention was often damaging and traumatic. This bill includes measures to improve care and support of autistic people, reducing reliance on hospital-based care, and that certainly is good and it's welcomed. However, there are aspects of the bill which concern me, and I've had a chance to discuss this with my noble friend, the Minister. I've been fortunate to have a number of fruitful meetings and discussions with the team from the Autism Centre of Excellence at Cambridge, and as a result, they and I share some of the concerns. Firstly, the government has said, for those with a learning disability or autistic people, the 1983 Act will be amended to place a limit of 28 days for which they can be detained unless there is a co-occurring mental health condition. My noble friend mentioned this in the opening remarks. My Lord, I stress again, autism is not a mental health condition, but given that 8 in 10 autistic people experience mental health issues, without the right safeguards, there must be concern that the new provisions could simply lead to a continuation of the current intolerable situation. And I hope my noble friend, as I said, who kindly recently met with me and discussed these matters, will seek to assuage my fears on this point. The government has also said police and prison cells will no longer be used to place people experiencing a mental health crisis. Instead, patients will be supported to access a suitable healthcare facility that will better support their needs. The Right Reverend Prelate referenced to this in her remarks. My Lords, the Lampard inquiry was set up to look at over 2,000 deaths of people in inpatient mental health facilities, specifically in Essex, and it is believed that many of those who died were autistic. So I would say to my noble friend, it would be wrong simply to assume that simply by switching location where autistic people are detained is going to achieve a much better way of protecting them. The government has also said that the reforms will introduce statutory care and treatment plans, and I share the Cambridge Centre's belief that every autistic person who needs support should have access to a statutory plan to enable them to get the help they need. It should not take an autistic person falling into crisis and being detained in a mental health hospital for such support to be provided, which is often the case today. Autistic people who are at risk of falling into crisis should have a similar right to such plans to prevent inpatient detention becoming a risk in the first place. A focus on prevention would be in line with Wes Streeting's idea of reforms of the National Health Service. My Lords, it's recognised that the current system does in fact have a range of provisions, legal rights and safeguards which should, in theory, have reduced the number of people detained in inpatient mental health services. But the true fact is, published statistics show us this has not happened, with thousands of people still inappropriately detained. So I ask my noble friend to consider these concerns as the bill passes through the House in the committee stage and so on. There is a danger of allowing, even unintentionally, the creation of a critical gap between what happens at policy and legislative level and what actually happens on the ground. Without reckoning with this gap and setting up measures to ensure that what is said by government turns into real action on the ground, these reforms will not change the decade-long scandal of thousands of autistic people being detained inappropriately. To do this will require clear measurement, consistent and regular accountability, and the necessary funding to enable the National Health Service and other agencies to deliver the hope for change that we need from this bill.
My Lords, it gives me enormous pleasure to speak in this debate today. For me, this legislation is above politics, a real opportunity for constructive opposition, and I welcomed a call from the Secretary of State for Health, Wes Streeting MP, in July, asking if I would support the bill and assist in its progress. Yes, there are some aspects of the bill upon which we on these benches will wish to press the government. However, our view is that it is overdue and critical for so many people who have felt misunderstood and suffered serious neglect for too long. I feel lucky to have chaired the Joint Committee on the Draft Mental Health Bill. Everyone on the committee, apart from myself, had either professional and practical expertise and experience and/or powerful personal experience and knowledge through friends and families. We received evidence from over 50 organisations and many people who are service users, to whom we remain eternally grateful. We had many hours of strong debate and always managed to find a way through. Results sometimes involved compromise, but was also consensual, and I thank each and every member for their invaluable contribution, together with our advisors and the brilliant Alex Ruck-Keane KC for his extraordinary drafting skills. I also thank the clerks and officials who worked skillfully against a very strict timetable. I want to first pay tribute to all our medical staff who work in this complex and in many ways challenging field of medicine. My sincere admiration for them and the difficult choices and decisions that they must make knows no bounds. A key point for me, and I speak as a lawyer, is that so much that directly affects the well-being of patients must be improved, not necessarily by legislation that can hamper positive change, but through a step change in culture to genuinely value every individual and improve their lives through choice, dignity, through support and advocacy. The bill seeks to address this, though it lacks a key tool, the use of technology and drive for data, which I urge the Minister to consider. The process of amending the current acts speaks volumes. Would that we could have torn up all the current acts and started again with a fused approach to treating mental health. But we were persuaded that it would just take too long. It's taken too many years to get this far, and now change is urgent. I have time to touch upon just a few of the many aspects of this bill. It is right that the government has agreed to embed in primary legislation, and here I say to Lady Barker, we have good news. They're going to embed in the legislation what I call the Wesley principles: choice and autonomy, least restriction, therapeutic benefit, and the person as an individual. Each principle should be tested against implementation of current proposals, future reform and change to ensure that patients as individuals remain the heart of the matter. Least restraint is a key reason for reform, though in practice it's a difficult balance to strike. As the Wesley Inquiry report makes clear, as a society we now benefit from a greater understanding of mental health. However, society has, at the same time, become much more risk-averse. Much of our debate centred around the need to address all avenues of least restraint, particularly given the current inequalities of outcomes against the risk of unintended consequences for the protection of both society and the therapeutic benefit of the patient. To apply the principles, we need the data to track every patient and their outcomes. My Lords, I remain appalled at the lack of information and communication across the NHS, which has a negative impact upon so many lives. Each time a person is moved, they're registered as a new patient. How much does that contribute to flawed data and poor outcomes? I do urge the Minister to look at this. A key missing element is, as I have said, technology. And I don't mean some clunky one-size-fits-all NHS-wide system. In short, we need to swiftly develop a national data set to allow for real-time monitoring and accountability, evaluating variation and inequalities, understanding medium and long-term trends, and informing future policy decisions. For choice, dignity and autonomy, we recommended a statutory right for patients who've been detained under the Mental Health Act to request an advance choice document to be drawn up and recorded in a way that is accessible digitally. There is no mention of digital in this bill. Instead, the bill introduces duties on integrated care boards, NHS England and local health boards in Wales to make arrangements so that people at risk of detention are informed of their ability to make an ACD, a written statement, and be supported to make one. Our report referenced the potential for creating ACDs via an app similar in some ways to one already working for end-of-life palliative care to support all patients. Simply put, it's a no-brainer and transformative, easily accessed by anyone, either on a mobile phone or even on a patient's clothes. So when that person is in crisis, there is an instant critical guide to who that person is that would greatly assist the police if they're in attendance and those in A&E. My Lords, I'm very hopeful that this approach and other smart, cost-efficient moves will be in the code of practice. Implementation of reform requires constant oversight. We recommended the appointment of an independent mental health commissioner with overarching responsibility to ensure consistency of delivery of the government's priorities for patients across England and Wales. My Lords, this is not about the government losing control. On the contrary, it's about an overarching small body with the ability to focus upon consistency across the whole sector, ideally using digitised national data to track and monitor implementation of the reforms over a period of years, working with the associated NHS bodies to promote better outcomes. So I ask the Minister, who else will do this? Furthermore, we must address unacceptable racial disparities and inequalities among particularly black men who, as we have heard from my noble friend the Earl Howe, who are 3.5 times more likely to be detained under the Mental Health Act and 7 times more likely to be placed on a CTO. But how is that data collected and verified? Indeed, the facts could be worse. Our report was clear that better outcomes would be achieved and inequalities reduced if each health organisation introduced culturally appropriate advocacy and appointed a responsible person to collect relevant data and publish and oversee policies to address these inequalities. My Lords, a Mental Health Commissioner could ensure that this is done. Mental health services currently operate in a static world. What happens when someone has a crisis far away from their local authority? We heard on a visit to SLAM in Lambeth that patients sometimes travel miles to Lambeth when on a downward spiral to receive, in their view, better treatment there than within their local authority. More reasons for data, accurate data, my Lords. Another area of critical importance is with respect to children and young people. Issues highlighted in our report, including the role and profile of nominated persons, detention in adult wards, and conflict with the Children's Act must be clarified and assurances given to families and their young. Investing in and building the right community support and action plan for those people with learning disabilities and autism no longer detained under Section 3 is critical, as is monitoring the outcomes for those with learning disabilities and autism who may be at risk of or being detained under the Mental Capacity Act or through the criminal justice system instead. This is an area where our committee had very strong debate, concerned about unintended consequences that might impact upon the patient and or society at large if the right protections, including safe spaces, were not in place. Is the government content that they have achieved the right balance? My Lords, I feel I must record, because I want to be helpful to the government, that our committee had one opportunity to put some of the crucial questions and test the opinions of around 18 officials from DHSS and the MOJ who'd worked on the bill for 4 years. That meeting was cut very short because one official said she had to collect her child from school. So all 18 walked out. My Lords, that must not be allowed to happen again. Priorities must be set for implementation of the many proposals, and there needs to be a significant increase in capacity right across mental health services, all of which requires enormous investment. My Lords, I wish the government well, and particularly the noble Baroness Lady Merrin.
My Lords, this is a long overdue bill, as many have said, and I hope it will progress through the House as soon as possible. Quite why it's taken 6 years for Sir Simon Wesley's report to be acted on, I'm not sure. But I'm particularly pleased that we've got advanced directives in, even if in this slightly watered-down form. There are, however, some rather troubling changes that have been squeezed in recently for reasons it's difficult to understand, and I shall want to explore those at committee. There are differences between criteria for Part 2 and Part 3 of the Act, for example, which is very bizarre. And I'm scared that the changes in relation to learning difficulties and autism, in spite of all the good intentions, will be extremely difficult to implement. There is throughout this bill an assumption that if you change the legislation, it happens. But we know very well it doesn't, and it takes years to implement. So I'm very concerned about that overall. But having said that, I'm now going to remain on that theme that Baroness Barker picked up, because I think we're going to leave the rest to committee. We're going to have very detailed stuff at committee. It's now 20 years since I came into this house with the certainty of the optimistic new girl that we would see a new mental health bill that addressed the deeply flawed legislation that we've been living with since 1959. But I'm pretty sure now that I shall leave this house as having seen no fundamental change. I'm ashamed that in England and Wales we're falling so far behind many other countries when we used to be in the advance in devising mental health law fit for purpose. Scotland is 20 years ahead. Northern Ireland is now too. I was told back in 2017 by Simon Wesley and others it would take 10 years to develop a unified mental health and capacity bill. Well, if we started then, we'd be almost there by now. We tinkered with the 59 Act in order to produce the 83 Act. We added a new Mental Capacity Act in 2005 that cut across mental health legislation. Then we added the ludicrously undeliverable deprivation of liberty safeguards and added tiers of bureaucracy to an already overburdened system, all the time reducing time for clinical and social care professionals to spend time with patients and more time filling in forms. The new bill makes no attempt to address the complicated relationship between the 83 and 2005 Acts, or how they're meant to be used for individuals. And this is particularly difficult for patients with both learning disability and mental disorders, and also older people with dementia, where people are tossing up which bill is going to be used. It's clinically ridiculous. So I would like to see a bill that addressed all mental health and capacity issues, putting capacity for decision-making at the heart of the bill, consistent with the United Nations Convention on the Rights of People with Disabilities, which we currently contravene and have done since the implementation by the UN in 2008. The human rights implications of the current bill are profound. It does not address the fundamental rights of thousands of mentally ill people, primarily because of the absence of decision-making capacity at the heart. We accept that patients with physical disorders can make decisions that may be seriously detrimental to their health or safety. In contrast to this, mental health law capacity plays little or no role in decisions to initiate psychiatric treatment against a patient's wishes. The criteria for involuntary treatment for mental disorders fails to respect the autonomy of the patients. The key considerations are the presence of a mental disorder and risk to the patient's health or safety. For persons with physical disorders, their personal values are given dominion. Those with mental disorders are not accorded this privilege in this bill, even though we make such a meal of it in the Mental Capacity Act. There is an underlying assumption that mental disorder necessarily entails an inability to make sound or rational judgments. But even in the most ill patients, those admitted to acute psychiatric wards, 40 to 60% retain full capacity. People with mental disorders are unusual in being liable to detention, usually in hospital, because they're assessed as presenting a risk of harm to others before they've actually committed an offence. This constitutes a form of preventive detention that is selective. We spent some time in this chamber a couple of weeks ago debating indeterminate sentences for people in prison thought to pose a continuing risk in the community. There was widespread agreement here that it was an iniquitous thing. And yet mental health law allows the detention of those with mental disorder on the basis of risk alone. How can that be how can it be justified? There's no evidence that risk is easier to assess in those with mental disorder, or that violence is more predictable in this group. And it's an expression of the prejudicial stereotype that people with mental disorder are intrinsically dangerous and that's contrary to research evidence. It doesn't mean that people's dangerousness is unimportant. If it's reliably linked to an individual's mental disorder, then if a person lacks capacity, involuntary treatment may be justified. But if the patient has capacity, protection of the public becomes the sole interest. Now, I do not deny there are problems with capacity-based regime. Many people think you have to fudge the decision, but I would say it was because they don't understand the fundamental ways to assess capacity and the full influences on it. One of the aims of this bill is to reduce sections. The number of new sections, as we know, has rocketed again. Last year, there were something over 52,000 sections and a further 5,000 or so placed on a community treatment order, and 140,000 people on a mental capacity deprivation of liberty safeguards. If the aim of the new Act is to reduce detentions, I can't see how. The discharge rate from tribunals has reduced from 25% in the mid-80s to about 6% today. How is it going to happen exactly under this legislation? I don't see how the overrepresentation of black people in the detained population is to be addressed by this Act. We need a completely different new way of assessing people and allowing people to get access to services that are sensitive to their needs and providing something that they are actually wanting to access. I can't think that there's anything new in this bill which reflects new thinking that is going on about how you encourage people to access bills when they first access services when they first begin to feel ill. The bill has nothing to say about restraint and seclusion. The bill does not address the hundreds of people in prison system and their non-consensual treatment except to speed up those that are suitable for transfer. The majority of mentally unwell will never be even considered for transfer, but they have terrible problems which really impact on the prison system tremendously. And finally, it's now 14 years since the Mental Health Act Commission was abolished, replaced at first with the Mental Health Commissioner, but now by the totally inadequate low-profile CQC, which has no legally qualified members, no mental health representation at executive board level. Whereas the former chair of the Commission and vice chair had direct access to the Secretary of State for Health, as I'm sure the noble Lady Bottomley will remember. She got tired of seeing us, I should think. Mental health does not now appear to have the same direct influence. Perhaps it's not surprising that mental health appears only on the government agenda where there is some crisis that has been brewing for years, or as now after meandering for years through our scrutiny and committee systems. My Lords, I've had my say. I'm not going to raise this issue again. I felt I had to say it once. I will throw myself into the committee stages with enthusiasm and hope we can get this bill through. But I do hope one day I will get the mental health and capacity legislation that we really need.
My Lords, it is a great pleasure to be able to contribute to the second reading of this very important bill, albeit, as other speakers have already said, a bill that has been too long coming. I would like to say, first of all, that I wholeheartedly welcome this bill. I would like to thank the government and commend them for bringing this bill forward so quickly in their term of office. And I would also like to thank the Noble Baroness, the Minister and the Secretary of State for the meeting that they held with me earlier today. And as others have said, I would also like to look back and thank Professor Sir Simon Wesley and his team, including, not least, the Noble Baroness, the Baroness Neuberger, for the work that they did, invaluable work that they did, that has led to this bill before this House today. And I would like to say a particular thank you to those with lived experience, those people who were willing to come forward and inform and advise the review panel, but also the pre-legislative scrutiny work, and at other stages too, so that their experience could be, so that the bill could be based on real experience, not just on what politicians, and dare I say it, the civil servants thought would be the right thing to do. So, as I say, I absolutely welcome this bill. And when, in October 2017, Sir Simon Wesley was commissioned to undertake the review, there were a number of reasons that led to that. The first was the one that the Noble Baroness, the Minister, has already referred to, the Mental Health Act 1983, over 30 years in place, had some amendments subsequently, but was felt to be out of date. Society and clinical treatments had moved on. There was a need to look at it. But I think for me, there was a more fundamental issue, which was the fact that so many people who found themselves in mental health crisis felt that somehow at those points of crisis, they were people to whom things were done, to whom society did things, rather than people who were able to be part and involved in that decision-making. That they lost their human dignity in the processes that they went through. There were also issues about the family members who were concerned either that they weren't listened to, because they felt that they knew when people were coming to points of crisis, or family members who felt they were shut out from the discussions about their relative who was potentially at a point of crisis. And then there was the overuse of detention. And reference has already been made, and I'm sure will be made by others in this debate, to the racial disparity in the use of detention, which is a matter which should concern us all. And of course, there was also the question of the use of detention for those with autism and learning disabilities. All of those issues underpinned the reason for looking at a review of that Mental Health Act 1983. The first point, I think, has been that issue about the loss of dignity, the way in which people in mental health crisis are treated, I think is, and I hope will be dealt with, by those very first principles that appear in Clause 1 of the bill. And I would particularly draw attention to the fourth of those, the person as an individual, matters to be addressed, treating patients with dignity and respect, and considering their attributes and past experiences. Although I do accept, as the Noble Baroness, Baroness Murphy, the Noble Lady Baroness Murphy has just said, that it isn't enough simply to put it on the page of a piece of legislation. Actually, for that to be enacted, it requires changes of culture, changes of attitude from all those who are dealing with those who are in mental health crisis. Part of this sense, though, of people being able to feel that they are making decisions for themselves, of course, is the advanced choice document that is enshrined within this legislation. I'm sure the government will want to think carefully about the matters that might encompass, and indeed think carefully about its interaction with potential future legislation. The issue of the nominated person, I wanted to pick this up. I mentioned this question of families feeling that they're sometimes cut out. But of course, as we know, sometimes for the individual with mental illness, with mental health problems, actually the nearest relative, that family member, may not be the most appropriate person to be the person who is the nominated individual for them, because that individual may actually be somebody who, the tensions can lead to increased difficulties for the person with mental illness rather than reducing them. And so I think that ability for somebody to nominate somebody else, nominate the person they want to be there, is absolutely critical. But it will, as the Noble Lady Baroness Watkins said, she referred to it in relation to children, but I think in general it could create some tensions with family members who feel it is their right to actually be that person alongside the individual who is in mental health crisis. But having said that, I do believe that that nominated person point in the bill is absolutely appropriate. I wanted to focus just also on the questions of detention. I've referenced that we need to look very carefully at the inappropriate detention or disparity of detention, racial disparity in detention. But I also want to comment particularly on the issue of police. And I'm pleased to see the outlawing of the use of police cells and indeed prisons as places of as first places of safety in this bill. Of course, this is the culmination of work in progress, which there was voluntary work with the police to encourage them to, and the health service in the 2012 and subsequently, to help the police ensure that for that person at mental health crisis, the first person they saw was not a police officer, and they were not taken to that police cell as a place of safety. That work then, of course, we then ensured in the Policing and Crime Bill in 2017 that police cells could not be used as places of safety for those under the age of 18. This takes it that bit further, and I think it is absolutely right that this bill does that. And it's right to do it for the person, for the individual who is in mental health crisis. It's also actually right to do it for the police, because one of the issues that was constantly made reference to me by police officers themselves was their fears and concerns about the fact that they were being expected to deal with somebody who was in mental health crisis when they had no training, no capability of actually knowing what to do in those circumstances. And of course, it is bad for the individual too, if they're being faced with somebody who has no understanding of actually what their condition is or what they should, how they should be dealt with. But if I may gently say to the noble Baroness Minister, in 2015 we put £15 million into providing alternative places of safety. In 2017 the government put £30 million into providing alternative places of safety. The government is now putting £26 million into providing those alternative places of safety. It is easier to say this from this side of the House, but the government might wish to consider those figures, if I can put it like that. Can I also suggest to the government that they consider the alternative places of safety as not just necessarily being a healthcare facility, but there are many places in the third sector who are able to provide those facilities, and the government should look at that as well. And then finally, if I can just say, I think we also need those facilities in order to try to ensure that people are less likely to get to the point of crisis. And if they're less likely to get to the point of crisis, they're also less likely to turn up at A&E because they are in crisis. So there will be a win-win for the individual concerned and for the government and for the health service. So overall, I welcome this bill. I think there's some very good provisions within it. As we've heard, it will be subject to detailed scrutiny in this House, but it's no bad thing, I think, that I can say this now, that it started in this House. So I welcome it and look forward to its passage through this House.
My Lords, it's a pleasure to follow the noble lady. I remind the House that I worked clinically as a psychiatrist for about 35 years. Indeed, I'd been a consultant for 2 years by the time the 1983 Act was introduced, and I argued then as now that mental handicap, as it was called, had no place in legislation. Others disagreed with me. Profound changes in societal attitudes alongside advancements in the understanding and treatment of mental illness have occurred during my career. I do agree with the noble Lady Baroness Barker and my noble friend Baroness Murphy that fusion legislation really should have been considered. My Lords, there is no minimum age limit in the Mental Health Act, meaning that its provisions apply to children and young people as well as adults. The Joint Committee, of which I was a member, recognised their unique needs, saying that this is, and I quote, a crucial opportunity for the government to strengthen the rights and protections for children and young people. We must never forget that the mental health of babies, children and young people is fundamental to the mental health of the adult population, and that we cannot legislate for the treatment of serious mental disorder without taking mental health seriously from the very beginning of each person's life. Psychiatry's past has included some harmful and forced interventions rather than the preventative approaches, early intervention and evidence-based treatments that are so needed. This bill aims to safeguard dignity, autonomy and ensure best practices for all, including people with learning disabilities and autistic people. A major current concern for me is that there are nearly 2,000 people with a learning disability and autistic people in psychiatric hospitals, usually because of a lack of individually tailored support and housing, and having an average stay of 5 years, and because of the shortage of effective treatment options in the community, and the lack of training for the wider mental health workforce. My heart breaks. The report of a review that I chaired and was published by the government last year shed light on the harrowing realities faced by many of the 100 or so of those 2,000 in hospital who are being detained in long-term segregation at any one time. The systemic failures we found reflected a troubling over-reliance on detention as a substitute for meaningful care, despite such detentions often lacking therapeutic goals, a pattern that unfortunately affects other patient groups as well, including those with personality disorders. Historically, my lords, policy and practice have overlooked complex intersectional vulnerabilities, including learning disability, autism, gender, race, poverty, and physical health issues. Marginalised groups, especially people from racialised communities, are detained more often. Trauma histories may be compounded by the excessive use of medication and restrictive practices which contain people with an eye to safety, but disempower and just don't support recovery. People need better adapted psychological therapies, but are less likely to access them. And poorly coordinated discharge processes further trap individuals in a dysfunctional system. My lords, this violates people's human rights and ethical care standards. As a long-time advocate for people with learning disabilities and autistic people, one of the bill's most significant reforms for me is the removal of learning disability and autism as standalone grounds for detention under Section 3, Part 2. This change is complemented by new duties on health and care bodies to provide the community-based support and therapeutic approaches needed to prevent unnecessary detentions. But legislation alone will not provide better care. The right people in the right place with the right skills are needed. And so the bill introduces mandatory care, education and treatment reviews which aim to create personalised care plans and to facilitate timely discharges. And additionally, dynamic support registers are intended to track those at risk of crisis, allowing for early intervention before issues escalate. Advanced choice documents could also be valuable for choice, safety and care. My lords, the National Autistic Society, MENCA and several other charities have welcomed the Mental Health Bill as a step towards safeguarding the rights of individuals with learning disabilities and autistic people. All stress the need for robust support systems, including housing and social care. These are essential to prevent unnecessary admissions, emphasising that the bill's success depends on effective implementation, accountability and investment, substantial investment in community services. They also request a new action plan to replace the Building the Right Support Action Plan. This is particularly urgent when targets to reduce inpatient numbers of people with learning disability and autistic people have been repeatedly missed over the last decade, and only 1 in 5 integrated care systems have currently met the March 2024 target for reduction of inpatient numbers. Can the noble lady, the Minister, confirm whether such a plan as is being requested will indeed be co-produced and implemented with the help of people with lived experience, with families, campaigners and relevant bodies, alongside the implementation of this legislation? Both the Royal College of Psychiatrists and the BPS have cautioned against removing autism and learning disabilities as standalone criteria, unless there are substantial improvements, warning that this could divert unsupported individuals into emergency services or the criminal justice system. Easy to say, better not to do it. But we must use this as a lever to change the culture of care and support for these groups of people. We don't want to risk criminalisation of people's mental health needs. We don't want to disproportionately impact already marginalised groups. I ask the noble lady, what assurances can government provide to ensure adequate funding to deliver minimum safe services in the community? Services such as early prevention measures, rapid response teams, crash pads, effective therapeutic approaches within the community. Indeed, could these alternatives be mandated? The compulsory detention and treatment of individuals with personality disorders under Part 2 of the Mental Health Act is another issue. Personality disorders stem from relational difficulties and cannot be effectively treated in restrictive inpatient settings. And research shows that admissions without structured, evidence-based psychological interventions provide no benefits and can indeed worsen symptoms. My Lords, why is Section 117 Aftercare limited to Section 3? Social and healthcare should be integrated for all patients based on need, not the section they were detained under. For example, a financial crisis causing suicidal thoughts in a farmer might lead to a Section 2, when a social prescription might have been effective. After assessment, they will return to the same situation without appropriate support, such as their need for legal or financial advice to resolve the crisis. The new Mental Health Bill gives us an opportunity to address the stigma that shaped policy in the 1980s, to create a legal framework which keeps pace with scientific advancements. We need to reframe our focus from risk management to supporting accessible evidence-based community interventions, ensuring care aligns with ethical and therapeutic principles and prioritises a rights-based person-centred approach. My Lords, our actions now will shape mental health care for the 21st century. Let us enact compassionate and progressive reforms that future generations will respect.
My Lords, always a pleasure to follow Baroness Hollins and her expertise in this area, and declaring my interest in the register, I am very pleased to make a very short contribution to this debate. It has been some time coming. Following the excellent review of the Mental Health Act initiated by Baroness May, Sir Simon Wesley produced his report in 2018, and then a draft bill was published by the last government, as we've heard, followed by detailed scrutiny by the joint committee of both houses, which I was pleased to be a member of, and which was so admirably chaired by Baroness Buscombe. But it was disappointing at that point that the deliberations were paused, but delighted that the new government, following a manifesto commitment, immediately introduced this bill, which everyone has welcomed today. In the time available, I will only focus on a few areas. First, the proposed changes under Part 3 of the bill, essentially the interface between mental health and the criminal justice system. I am delighted the bill proposes under Clause 35 putting a statutory time limit of 28 days for the transfer of acutely mentally ill patients held in prison to appropriate hospital provision. It is now well recognised that the prison environment and care capacity is detrimental not only to the prisoner, but also other prisoners and staff that care for them. I made a similar recommendation in my independent report to government in 2009, nearly 16 years ago, albeit with the perhaps unrealistic time limit of a 14-day transfer. Clearly, you have to be patient and persistent to achieve legislative change. Secondly, Clause 46, the removal of police stations and prisons as places of safety. Again, I made related recommendations back in 2009, but am obviously now pleased that there is overwhelming recognition that both these facilities are not appropriate as places of safety. Clearly, the detailed examination of these clauses will be required at committee stage to ensure the wording delivers the intention of the proposal. For example, when will the clock start on the 28-day limit? Further, to be effective, investment in alternative community health-based provision will be required for places of safety. and also investment in liaison diversion services to ensure that only those that need to require a place of safety. Otherwise, as we've heard, A&E departments will continue to be the default position at huge cost to the NHS and to the police service. And we also need additional acute mental health beds in every local area to ensure timely transfers and to make the legislative changes a reality. A comment here that there is also concern that children and young people are still inappropriately placed in settings out of the local area and on adult wards, well articulated by the Children and Young People's Mental Health Coalition. I believe that it's imperative that the bill strengthens safeguards against this and also recognises the Joint Committee recommendation on stronger procedural requirements where such inappropriate placements are considered, including a requirement that such a placement is demonstrably in the child's best interests. There are many positive elements in this bill, as the Minister clearly outlined at the opening of this debate, including improving the patient experience, improving patient choice and autonomy, and limiting the detention of people with learning disability and autistic people without a qualifying co-recurring mental health condition, all of which and many others, as we've heard, will be carefully considered during the committee stage. However, I do believe we need further debate on where the principles outlined by Sir Simon Wesley are actually placed within this bill. And I am particularly disappointed that the government have not currently accepted the recommendation to establish the role of a mental health commissioner and seemed silent on the issue when the bill was introduced. As we have heard, the Joint Committee recommended that this post be statutorily positioned, and the Mental Health Commissioner should be created with a number of roles, which I'd like to briefly elaborate on now. The Mental Health Commissioner should be a voice at a national level, promoting the interests of those who are detained and are likely to be detained under the Mental Health Act, and of their families and carers, raising awareness of their needs and challenging stigma and stereotypes. And it should work in conjunction with the Care Quality Commission and other bodies to make recommendations on reforming further mental health law in the direction of more rights-led and fused legislation, such as we've heard on the Mental Capacity Act. And critically, it should be a mechanism for tracking the implementation of the reforms in and associated with this bill and other legal changes, essentially and particularly with the inclusion of the provision of data to understand how the bill is actually operating. We saw the role of the Commissioner being primarily to act as a watchdog to oversee the direction of travel for the key reforms in the Mental Health Act and mental health policy generally, overarching the whole government system. This has been supported by many organisations working in the mental health field, including the Centre for Mental Health, of which I'm an ambassador, who added, in addition to overseeing the reforms to the Mental Health Act, a commissioner could play a wide-ranging strategic role across all government departments. Finally, a few further words about resourcing and implementation, which will be crucial to the success of this legislation. Again, the Joint Committee recommended that the government should publish a comprehensive implementation and workforce plan alongside the bill, and key milestones detailing the implementation of the bill, and crucially how they link to milestones in the implementation of the NHS 10-year plan and other government initiatives. These should include milestones on workforce development, not only mental health staff, but also allied health professionals such as speech and language therapists. And again, I should declare my interest as Honorary Vice President of the Royal College of Speech and Language Therapists. Also milestones on training, advocacy and community care capacity, as well as on numbers of detentions, length of stay and critically reducing racial and ethnic inequality, with a statutory duty to report annually to Parliament on the progress against these milestones during the implementation period. Disappointingly, unless I have misunderstood the explanatory notes to the bill, the Government has only so far offered a financial assessment over a 20-year period, not at all coherent with the NHS 10-year plan. However, in conclusion, I am very pleased that we are debating this incredibly important bill now and in the coming weeks and months, and to try to ensure that we go a long way to producing a progressive Mental Health Act fit for 2025 and years beyond. I look forward to the Minister's response at the end of the debate.
My Lords, it's a great pleasure to follow the Noble Lord Bradley, who was the MP for the constituency where I lived when I was a student. In those days I campaigned against him, but listening to his speech today, I'm sure we'll be campaigning together on, at committee stage on some of the reforms maybe that's required within the bill. My Lords, this bill is a welcome travel of direction for mental health legislation within the United Kingdom, but it is only an extra stop. And I think, as other noble lords have said in this debate, sometimes we may have to look at the bus that we're actually on, the underlying legislation. Now, that bus was built when I was 17 years old, if we go back to the 1983 legislation, and it was last MOT'd 17 years ago in terms of its amendments. And so I do believe that while these are welcome, there is still a fundamental issue about the basis of what we are travelling on. But I understand that the problems with that. And the questions that we're really asking under this bill is quite limited in sense of the balance between individual freedoms and public protection when it comes to detention of individuals. And because we infrequently look at such legislation, I think that we must do our best in committee stage to ensure that that balance is as best as possible, and wherever we can to take a person-centred, rights-based approach to this legislation and this bill. So, having said that, there are some pleasing points within the bill, including the tightening the criteria for the detention and compulsory treatment of individuals. It is welcome that the 4 key principles are mentioned, but it is a shame that they're not actually on the face of the bill and only in... No, they're not on the face of the bill. They are, my lords, to be in the down as guidance. That is what they actually are. And it is important, I think, that those of us who really support the principles do fight for them to be on the face of the bill going into committee stage. The advance choice documents are a welcome provision, but as many noble lords have said, they need to be fully accessible 24 hours a day, 365 days a week for those who will be caring for people who have given an advance choice document. And I do question why they are only for people aged 18 and above. I believe that if we are looking at Gillett competency, then there are issues about those who are younger who should be able to provide an advance care document. And I do worry that they are not a right as a duty, but all they are there to be given as a consideration. I do, my lords, welcome the rights to a nominated trusted individual, but many people who have been involved in healthcare will know it is not just having that person as a right, it is the way in which professionals then not only listen to that individual, but then carry out the rights of the advocacy that they provide. So I'm not sure, as we start with this bill, that the balance is correct, and in committee stage I believe that certain issues will have to be addressed. I've also, my Lords, looked at potential implementation of the bill, and it's always good to start with the impact assessment. And the impact assessment has some quite startling issues within there, which I think we would want to look at committee stage. For example, the community treatment orders are not meant to change for at least another 7 years. The implementation start is in 7 years' time. So the existing CTO regime will last for another 7 years, and at the earliest it looks as though they will start in 7 years' time, down in the government's impact assessment. For people with, and I'll come back to people with learning difficulties and autism in a second, the implementation for them not being held over 28 days and other provision in the community having to be available is in 3 years' time, according to the impact assessment, but there is no money in the next 2 years to start to provide for those community facilities. It is as though those community facilities will come on stream the second that the implementation date starts. So I'd question the government's planning on that and whether it is a realistic adaptation for people with learning difficulties and autism. And my passion and my focus probably will be, as we go forward in committee stage, on learning disabilities and autism. And that's because it is very personal to me. I have family members, very close family members, who are loving, warm, but very misunderstood by those who don't have a close relationship with them. And it's absolutely scandalous that in 2024, that having those two labels attached to you means that you could be detained under the Mental Health Act for more than 28 days. So I do welcome the fact that the provisions within the bill will move away from section part 3 and move to part 2 detention. But I do worry that that in itself will not stop detention of people with learning disabilities and with autism. Dolls, for example, will be used because these people are misunderstood. The legislation in itself will not change what happens to those individuals. Individuals who are seen as difficult and not a threat, but difficult, will be detained. And therefore, I think we need to look at how, as other noble laws have said, fused legislation needs to be used to ensure that, that those individuals are not detained using different parts of legislation. It is also worrying, my lords, as other noble lords have said, for people with learning disabilities and with autism, if they are under a Section 2 or detained under the Mental Capacity Act, they won't have access to Section 117 community facilities. It is quite fascinating that the very thing that says needs to be put in place to ensure that these people are not detained, by not having Section 2 provision of Section 117, are the very facilities that they don't get a statutory right to. And that needs to be looked at within the legislation, my lords. So there are many things to welcome within the legislation, but there are many, I think, further questions that need to be asked and need to be drawn out as we move forward, particularly regarding some of the contradictions within different parts of the legislative process that is in place for mental health provision within the UK, but also some of the rights-based approach which the government seems to not have in place, and I think we would want to explore those as we go forward.
Yeah.
My Lords, consideration of this bill has been greatly assisted by the thorough scrutiny and analysis undertaken by the Joint Committee on the draft bill and their compelling report published in January 2023. But Parliament will now need to look with care at the recommendations of the Joint Committee, including those not incorporated into the bill as now presented, and the justification for any omission. The first question tackled in that report was whether what was now required was fundamental reforming legislation rather than another amending statute. If I may follow on what the Noble Lord Scriven just said, in fact, the bus wasn't built in 1983. It was built, or at least the chassis was built in 1959, and we're still dealing with it. As stated in the report, however, the Mental Health Act 1983 is 40 years old. It has been amended multiple times over those years, making it hard to use even for experienced professionals. It is overly complex, especially where it interacts with the Mental Capacity Act 2005. For example, the committee noted attempts to both protect and empower children in these settings have resulted in a complex mixture of statute law and case law alongside the Mental Health Act that made assessing a child's rights to access certain safeguards in the draft bill, as it then was, complex and obscure. But for essentially good and pragmatic reasons, as explained by the Noble Baroness Lady Buscombe, the Joint Committee did not wish to introduce further delay or uncertainty, and so favoured the form of the bill being considered by them and now before Parliament. However, for the courts, the tribunals, the lawyers, and really all the other consumers of this legislation, the question will remain, as it was quoted, to quote in the invaluable Mental Health Act manual, if the Mental Health Act is to be modernised, is it appropriate to base that modernisation on a legislative structure that was established over 60 years ago by the Mental Health Act 1959. The process of bolting on multiple miscellaneous amendments to that structure over the years has resulted in an act which is overly complex, confusing and expensive to operate. Inevitably, those problems will be exacerbated when this bill adds further amendments to the 1983 Act. It is therefore to be hoped that the government will see this bill, as the Joint Committee put it, not as the end or even as a pause in the process of reform of mental health legislation. Meanwhile, the Code of Practice under the 1983 Act will need, and I understand will now receive, further revision and updating once this bill is enacted to cover the stronger requirements of the new legislation and to provide clear guidance to meet the needs of patients and for all those who operate the changes. Turning to some of the detail of the bill, it is certainly welcome that it gives recognition to the real problem that there are too many autistic people and others with learning difficulties who have been detained inappropriately and for far too long. It is also welcome that the bill removes police stations from the definition of a place of safety in the 1983 Act. Inevitably, the police will continue to have to deal with disturbed and distressed people who are suffering a chronic or temporary mental health crisis. But these are people who should not be in police stations any longer than absolutely necessary, particularly if expert or assessment or treatment are required. It is to be hoped that the changes will relieve the police of some of the difficult decisions as to risk required under the existing Code of Practice. But these changes, as others have said, will not work without sufficient community alternatives. And it will not, as the Noble Earl said, be helpful if it simply passes the problem onto an A&E department. I don't want to get anecdotal, but I had a brief admission to A&E, happily not long lasting, but it was extraordinary to watch the staff in that hospital coping with a very determined and very disturbed man, which I couldn't see the end to, unfortunately, because luckily I was released. But nevertheless, it is a problem which does need to be thought about hard. By contrast with the ethos when I started as a lawyer, all courts now strive to ensure that people are not defined by their mental health problems. Even if it is not always possible to prevent those with mental health problems from entering the criminal justice system or to divert them from it once within it, professionals within that system need help to deal with these people and their problems. And therefore the improved provisions for transfer of prisoners to hospital, including those detained under the Immigration Act, should be valuable, but will always depend upon compliance with the Code of Practice, which requires the need for inpatient treatment for a prisoner to be identified and acted upon quickly. The same problems apply when the criminal courts are considering sentencing options. The courts depend on the probation service and on legal representatives to draw attention to the possible need for psychiatric reports and detention. Having sat as a judge in the Crown Court, I can convey the real exasperation of the judiciary when necessary reports are not available or when suitable hospital places cannot be found without further delay and hearings in an overloaded court system. Lords, on the different topic which has been referred to, the bill will implement recommendations about replacing the existing nearest relative with the nominated person under the principle of patient choice and autonomy. I do have some concerns relating to the selection and replacement of nominated persons and the complicated provisions within the bill. Nevertheless, now is perhaps not the time, and I will leave that to committee stage. But nevertheless, it does need, I think, to be looked at again, particularly with some need to focus on the consultation at the very least and recognition of the legitimate interests of parents and others with parental responsibility. On this topic, I would also question, but again leave to a committee stage, the continued use of the county court for applications to terminate appointments of nominated persons. The use of the county court is left over from the 1959 Act at a time when there was neither a separate family court nor a court of protection. And I suggest that these would now be better equipped to deal with these applications. There are further points focusing on the needs of children, one of which has already been touched on. That was highlighted by Dr. Camilla Parker in her evidence and will strike a chord with many practitioners. It concerns the overlapping factors governing capacity and governing competence and the differing processes for assessment. Dr. Parker observed that even after 40 years we do not have clear, consistent criteria for determining whether a child is competent to make a decision. It would be helpful to understand the government's current intention, particularly if it's not intended to formulate any statutory tests. More fundamentally important is the location of the placement of children. This overlaps with the real problem which has been highlighted repeatedly by the judiciary, by the Luffield Family Justice Observatory and the Children's Commissioner of the use of deprivation of liberty orders, DOLs, using unregistered settings, not just adult wards, but unsuitable, unregistered settings in which to place children. Again, I would wish to return to this at committee stage.
My Lords, I declare an interest as a Vice President of the National Autistic Society, which I share with my noble friend, the Lord Tuig, and also having some responsibility for family members on the autistic spectrum. My Lords, like Baroness Barker, I too am a veteran of the 2007 Mental Health Act and the Mental Capacity Act, and was pleased when I came to this place to be able to be involved in the review of the Mental Capacity Act, something which I think would merit, with many other bills of this nature, to look at what actually happens after we legislate. My concerns with the 2007 Act were primarily community treatment orders, and looking at this particular Act, I see that they are to be altered, but I'm still minded to share the view of the charity Mind, who would like to see them abolished altogether. So I hope as we go through committee we can make substantial changes to what we have in front of us now. I was also concerned about the deprivation of liberty generally, and of course the situation as far as autistic people are concerned in relation to mental health services. I have to say I'm still concerned, but welcome the proposed changes to people with autism and learning disabilities to make it illegal to detain an autistic person or a person with a learning disability unless they have a coexisting mental health condition. Presently, of the number of autistic people detained in mental health facilities, 93% of the 1,385 of them are detained under the Mental Health Act. They are not voluntary patients. I make no apology for making the case for autism being a special condition that needs to be treated differently to other conditions. And I say that because apart from the Mental Health Act, the Autism Act is the only other only other medical condition which has its own Act of Parliament. That tells you something about it is different from other conditions, and both Houses of Parliament in 2009 passed this very short but very important Act that was introduced by my friend, the late Right Honourable Cheryl Gillen MP. So what is it about autism that makes it so different that we should have special regard to it as this bill progresses? I wanted to look first at how autistic people come into contact with psychiatric services generally. It is, of course, a spectrum. So we are talking about quite a wide range of conditions. And, of course, the old adage that if you've met one autistic person, well, you've met one autistic person. Because although we may look at commonalities between this whole group of people, they are all individuals and should be treated as individuals. Well, they come into contact through diagnosis, not so much now with psychiatrists, there's a wider range of people who diagnose autism, but they come into contact with psychiatrists, and I give apologies immediately to those eminent psychiatrists in this chamber. But over 32 years in this House, having taken up many cases and I hope assisted several members with their casework, I've seen what can often happen if a psychiatrist who does not understand autism, or even worse, receives a patient with an autism diagnosis from another psychiatrist, but will not accept that diagnosis. Shocking, shocking. Because so often, misdiagnosis can occur when somebody is admitted to a mental health institution, when the psychiatrist will not accept that diagnosis and starts to re-diagnose somebody, giving them treatment, medicated treatment, which quite clearly does not work. I've seen the results of that. I can particularly remember, fixed in my mind, is that of a young man who was a very good artist who, despite an autism diagnosis, that was overridden when he was admitted, and the diagnosis was no, this is schizophrenia. A very common mistake, interestingly. And as each medication was applied and didn't work, the ability of that young man to actually hold a paintbrush and produce the sort of work he produced before was completely diminished. So they come into contact with psychiatrists, and my point about psychiatrists is they must have specific autism training. There is a huge lack of psychiatrists generally, but particularly psychiatrists with that type of training. Also, although autism of itself is, as Lord Tuig quite rightly said, is not a mental health condition, people with autism can, of course, have a mental health condition, and they can have a learning disability. But, of course, out in the community, if an autistic person needs medication of one sort or another. And I'm not talking about drugs that are used for psychosis, but very often to help control anxiety, which is a very natural side effect of autism. Accessing the correct drugs through a psychiatrist is impossible in some parts of the country. It's very much a postcode lottery, because psychologists, who very often autistic people are referred to, cannot prescribe. So if you do not have a local psychiatrist who a GP can refer you to, then you have the only option is very often to pay privately to see the right person. If any of us had a cardiology condition, we would not expect to have to pay to see a cardiologist to treat us. And this is something which I believe this bill should address, the access to, the word appropriate is used so often, the access to appropriate care from trained, qualified people, whether it's a psychiatrist or a CPN or whoever. And the other thing about autistic people too, is that must be taken into account, is that so many of them have sensory side effects to their autism, of a vast variety of side effects, which perhaps may not seem very important to people who don't experience them, but it can be anything from lighting, noise, sound, proximity of other people to them. And again, these are things that need to be taken into account. When you take all these things into account, the things that have been said already in this debate, people being admitted to A&E, what a horror that is for any of us now. But frankly, for an autistic person, it can produce very serious results. I would like this bill to produce the right training. I would like it to produce the right services in the community, because for autistic people, the downward spiral into very severe anxiety is there when community services are not provided. And when I talk about community services, I'm not always talking about something that's going to cost a fortune. It's actually the low-hanging fruit of low-cost measures. And sometimes it can be as simple as something that provides somebody, or a child or an adult, with a friend, somebody with whom they can form a relationship. That doesn't cost a fortune, my lord, but when money is tight, and we know money is tight, those are the first sort of services that get taken away. And that downward spiral of an autistic person, when services are no longer provided or not provided in the first place, is what results in them needing to come into contact with the more serious mental health services that this bill will address. My lords, Baroness Watkins mentioned parental responsibility. We haven't mentioned yet in this debate lasting powers of attorney. Lasting powers of attorney for people who are able to sign them when they have capacity, something which may well be a very useful thing when people are denied access to their relatives or carers. And I hope we will include that in the bill.
My lords, it's somewhat humbling and not a little intimidating to follow on from so many insightful speeches from those at the heart of the issue. For me, as a bit of an amateur outsider, I broadly welcome the bill, but with some reservations which I'll pursue at committee stage. For the second reading, I wanted to suggest that we should always remember the cultural and political context of our deliberations and indeed definitions used, and I'll come back to that. We also need to remember the lessons of history. Locking people up for mental illness has been mired in ethical and political scandal over many years. We all can cite the former Soviet Union, where political dissidents were labelled mentally ill. But even in democracies, it wasn't until 1973 that the American Psychiatric Association voted to declassify homosexuality as a mental disorder. And don't let's forget those unmarried mothers who were sectioned in the 20th century. But even this misuse of psychiatric power, it is still possible to be a defender of liberty, such as myself, I hope, yet acknowledge the need for some people to have their liberty restricted because of their mental health. Many years ago, when I worked for Mind, this was a very polarising debate, but I argued then and continue to believe that when someone is severely psychotic or manic or out of their minds, then psychiatric coercion is not a violation of individual autonomy. That's because the subject at that point in time, and this is the key, at that point in time, is not autonomous in any moral sense. But isn't release different? And that gets me to the issue of community treatment orders. I too would like them to be abolished, as others have said. The general problem of CTOs is well explained by Dr. Ken McLaughlin in his pamphlet Escaping the Straitjacket of Mental Health, where he makes the point that while the case for compulsion can be justified at the point of hospital admission, when the patient is likely to be in an acutely psychotic state, he asks if compulsion can be justified at the time of hospital discharge, when the patient should have mental capacity restored. And prior to 2007 and CTOs, on leaving hospital, an ex-patient regained their full rights of citizenship, including the right to refuse medical treatment. The problem with being released with a CTO is you return to the community as neither a patient nor as a citizen. And this hybrid state is troubling in terms of compromising civil liberties. So I tend to agree with the comments by the noble Lord Earl Howe and others that at the very least I'd like to challenge why the bill will allow indefinite CTOs to occur. I agree with the Centre for Mental Health's call for safeguard of time limits, and then CTOs could only be extended if there was proof of proportionality for the individuals concerned. The question of indefinite coercive orders inevitably reminds us of the plight of those almost 3,000 prisoners held indefinitely behind prison bars under the abolished and discredited IPP sentence. Many of these prisoners, many of these people are incarcerated in prisons precisely because their mental health has deteriorated because they've been refused release, even on licence. A sort of unacknowledged section is happening here. What's more, shockingly, a wide range of experts now blame this very sentencing regime as the cause of IPP prisoners' mental distress. The hopelessness, the psychological terror, as it's been described, of never-ending sentences has literally driven prisoners to lose their minds, even to lose their lives through suicide. So while I'm delighted that this bill will remove the prisons from the list of places of safety, how does this help those IPP prisoners? They are deemed too mentally unwell to be released safely. Their illness is at least partly derived from a shameful state mistake. Yet IPPers are coercively detained indefinitely in institutions that this bill would have the state now deem as unsafe for those with serious mental illness. One case that has recently attracted headlines illustrates IPP's plight as it relates to the bill. 40-year-old Thomas White has served 12 years as part of his indefinite IPP for a non-violent theft of a mobile phone in 2012. According to his psychiatrist, Thomas developed his religious hallucinations and psychosis as a direct result of being on an IPP sentence. His sister Clara has been campaigning for over a year to have Thomas transferred to a hospital, but his recent assessment appointment was cancelled due to staff shortages. Clara notes despairingly, "We waited a long time to have Thomas assessed by a psychiatrist. We more than likely won't get the assessment again. The system is nothing but criminal. People like my brother are being seriously failed." James Firkin, Labour MP for Bury North, agrees. He says Thomas's indefinite imprisonment has had a huge detrimental impact on his mental and physical well-being. Thomas should be a patient, not a prisoner. Hear, hear. Things are little better for the general prison population. The annual report from the Chief Inspector of Prisons complains of high healthcare staff vacancy rates and chronic recruitment and retention issues. And in that context, Richard Garside, the Director of the Centre for Crime and Justice, concludes that the provision in clause 35 to introduce a statutory target of 28 days for transfer from prison to hospital, while welcome, feels aspiration rather than practically implementable in the current system. This sort of broader crisis of staffing and resources and whether it will hinder the bill, as we've seen in jails, is also mirrored outside the prison gates. Many briefings for this second reading that we've all received query whether the bill will deliver its promises as a consequence of such problems. I want to raise a related concern. I think that overstretched mental health services are not just a question of resources, but rather a consequence of a recent cultural trend. That is what I consider to be the problematic medicalisation of more and more aspects of the human condition. Ever greater numbers are being encouraged, often by government-backed policies, to view normal, if adverse, perhaps painful life events through the prism of mental illness. As a consequence, greater numbers of people now demand expert pharmacological or therapeutic intervention. Over recent decades, this huge increase in classification in the psychological realm has moved the job of diagnosis far beyond the field of psychiatry. A veritable industry of counsellors, therapists and psychotherapeutic practitioners now label an ever-expanding set of behaviours as mental ill health. As the numbers of labelled conditions has grown, those reporting they suffer from such problems has risen exponentially. And the stats bandied around are eye-watering. According to the psychologist Oliver James, a third of the adult population shows signs of psychiatric morbidity. The problems of worklessness and sick leave that the government is rightly tackling seem dominated by those who've removed themselves from productive work because of mental health-related problems. Student Minds reports 1 in 3 students experience clinical levels of psychological distress. But as it's now claimed students might suffer PTSD if exposed to certain literary texts, it's difficult to assess the clinical authenticity of so-called mental health epidemic amongst the young. But the main thing is that the pathologising of ever more aspects of life has unintended consequences, some pertinent to this bill. For example, we risk reducing the time and resources available to those who desperately need professionals' help if the system is clogged up with inappropriate referrals and arguably overdiagnosed conditions. And finally, there's a danger of confusing public opinion if the true horrors and tragedy of serious psychotic illness are relativised and given the same mental health moniker as unpleasant but mundane psychological challenges.
My Lords, I rise to contribute to what has been a fascinating debate so far. It's an honour to contribute to this debate, listening to so many learned peers around the House. In fact, earlier on I detected an almost come-by-our moment around the agreement of some of the aspects of this bill. I should declare my interest as the chair of the NHS Confederation, which is a membership organisation representing health and care leaders in England, Wales and Northern Ireland. We have the privilege of having 100% of all mental health trust leaders in membership. This debate is long overdue. Updating the Mental Health Act is long overdue. I couldn't help thinking that during the contributions of Lord Meston and Lord Scrivens, that if we were to go back to 1959, this House would be of archaeological interest before we got anywhere near where we've got to today. So we should start where we are and continue to make this bill the best it can be. Organisations, including the NHS Confederation, I should also point out that a member of my family is also on the autistic spectrum, so I get it, and people who have that experience also get it. Organisations like the NHS Confederation have warned that the success of reforms will be dependent on the wider infrastructure to support them. And my first question to the Minister is can she confirm that, as well as the important measures in this bill, we will see further details in next spring's spending review and in the 10-year NHS plan about how patients and staff working in mental health will be supported in years to come. This bill is welcome, not least because it's intended to stop people with learning disabilities and autistic people from being detained long-term unless they also have a serious mental health condition. but only when there is sufficient and appropriate community care in place to support them. It's clear, therefore, that a plan on how this capacity will be built up is vital. Otherwise, people will continue to be detained inappropriately. Can the Minister provide more details on what the Government will do to ensure that we see that capacity is built up so that people with learning disabilities and autistic people are able to benefit from the support that community care can provide? Concerns have also been highlighted to me from many of our members and many organisations that the changes for people with learning disabilities and autistic people may unintentionally risk these groups falling into the criminal justice system due to a lack of community provision, as mentioned by Noble Lady Baroness Watkins, not Lord Lady, definitely Lady, Baroness Watkins. Similar to the changes she referred to in New Zealand, which led to people with learning disabilities and autistic people sometimes being sent to prison and left neglected in the community or admitted to forensic facilities as secure patients, as they were unable to be detained under their equivalent of the Mental Health Act. I welcome the safeguards that the changes relating to people with learning disabilities and autistic people that will only be enacted once sufficient provision is in place. Can the Minister provide more details on what the Government will do to ensure that capacity is built up so that people with learning disabilities and autistic people are not inappropriately and indeed unintentionally detained for many years to come, often far away from home and for very long periods? The Government is committed to only enacting the changes to detention regarding people with learning disabilities and autistic people once sufficient community provision is in place to reduce the risk of these people falling into the criminal justice system. Again, can the Minister outline how the decision to enact this part of the legislation will be made? The reforms that we're debating introduce duties on commissioners to ensure an adequate supply of community services to prevent inappropriate detentions in hospital. Well, without a funded plan to build up this provision, there is a risk that the proposed changes to legislation will never be enacted and people will continue to be inappropriately detained. Can the Minister say what measures the Government will put in place to help commissioners get it right at local level? In addition, and as Lord Bradley mentioned, referring to the 28 days, some people are very concerned it's not long enough to complete a thorough assessment to identify if patients with a learning disability or autistic people have a co-occurring mental health disorder due to the complexity of what patients often present. Does the Minister acknowledge these concerns, and will she remain open to discussions with the sector throughout the passage of the bill so that the views of those who work day to day with vulnerable people, as well as the views of people with learning disabilities and autistic people and their families, can be fed directly into the legislative process? It's nice to note that many have referred to the stark racial inequalities in the use of CTOs and wider concerns around their use. However, mental health providers and many professionals agree that they can be beneficial to patients as they can be the least restrictive option, and we welcome the Government's commitment to reviewing CTOs. Can the Minister share details about the scope and timescale of this review? The NHS Confederation has raised concerns about high vacancy rates across the sector, which is bound to impact on staff capacity. Again, can the Minister give assurances that this will be addressed as soon as possible, if not as part of the legislation, then through the upcoming 10-year plan or the review of the NHS workforce plan, as mentioned by the Right Honourable Bishop of London and indeed Baroness Buscombe, whose points on data I also agree with. The NHS Confederation has pointed out that more opportunities for patients to challenge their detention is likely to increase the number of tribunal hearings, and this would require an additional 33% expansion of the inpatient responsible clinician workforce. Now, given that 10 to 15% of national consultant psychiatrist vacancy rates are currently around, this will be very challenging. With the Government set to publish an updated long-term workforce plan, as previously mentioned, for the NHS next year, can the Minister give an assurance there will be measures in this plan to specifically tackle workforce shortages in mental health? Referring back to the issue of racial inequality, the importance of the patient and carer race equality framework as the key vehicle in reducing the racial disparities that exist in the Mental Health Act and in wider services, which, for example, mean that black people, as has been mentioned, are far more likely to be detained under the Act or to be placed on a community treatment order than white people. The so-called PCREF is not part of legislation, but all mental health providers are expected to implement it. Concerns exist that the lack of understanding of the framework, as well as the lack of resources available, are hampering its implementation. Again, will the Minister consider using legislation to address these concerns? Racial disparities are a significant issue, and the NHS Confederation has described the disparities in rates of detention for people from racial backgrounds as unacceptable. I agree. For example, black people are more than 3 times more likely to be detained under the Mental Health Act. There is evidence that advanced choice documents reduce racial disparities in the level of detentions, and this led to many of the sector calling for them to be made statutory. Indeed, this was recommended by both the Mental Health Act Review and the Pre-Legislative Scrutiny Committee, which looked at the draft bill. Can the Minister set out why advanced choice documents will not be made statutory? Can she say whether she is confident that measures in the bill concerning such documents will help reduce those racial disparities in detention rates? There are very few evidential interventions that actually reduce racial interventions, so let's use the one that we know works. The NHS Confederation has highlighted concerns that the new criteria for detention set out in the bill, namely that serious harm may be caused, brackets, close brackets, needs to be defined. If it isn't, then we risk an inconsistency in how the definition is interpreted. Will the Minister come forward with a definition of what constitutes serious harm so that there can be no doubt about what this means in practice? Funding for new mental health crisis centres announced in the autumn budget was welcome, but we need to see more funding provided for the NHS and mental health in the coming years. As the Confederation has pointed out, successful implementation of legislation that we are debating will depend on ensuring that the workforce and resources are in place. That includes capital funding to improve the safety and therapeutic environments of inpatient wards. I've seen some shocking places, no doubt many of you have. Can the Minister say whether, alongside these much-needed reforms, we will see further funding for mental health in next spring's spending review? Speed dial. The Treasury. The Government estimates the overall cost of the reforms to be around £5.3 billion for housing, health and social care costs, and £313 million for costs to the justice system in England and Wales. The upcoming 10-year plan and next spring's spending review are key opportunities for the Government to acknowledge what is needed to enact these reforms. 2 minutes. The money for the NHS in the NHS budget was very welcome. I'm a big fan of £22 billion for the NHS. But will the Minister give an assurance that further funding will be made available so that these reforms have the best chance of being effective? The Government's commitment to shift more care into the community is welcome because it supports better patient outcomes and is more efficient use of funding. However, the NHS Confederation and I are among those who have pointed out that we need to make sure that the right provision is in place for that community care. Can the Minister provide assurance today that the Government acknowledges this, and can she set out what the Government plans are to ensure that we have this provision? As the NHS Confederation pointed out recently, on behalf of our members, people with mental health needs and those with learning disabilities.
Order. I
2 seconds.
Yeah.
And autistic people.
Let me just point out that the voluntary limit of 9 minutes is voluntary, but there are a lot of people wanting to speak.
I know. And I've got two things to say, and then I'll finish, honestly. Waiting for too long for appropriate care and support. The mental health estate has also experienced years of underinvestment. So can the Minister give assurance today that alongside this bill, the Government will use every opportunity it has with the 10-year plan and the upcoming spending review to ensure that we see further investment in both care and support for those who need it and also into the mental health estate? Thank you for your patience.
My Lords, it's a pleasure to follow Lord Adeboali, and I won't have quite as many questions as he has for the Minister, but I would like to say that I very much agree with what he says about community treatment orders, which I will return to at the end of my remarks. Like many other peers, I welcome this bill, which will hopefully improve the treatment for people who are detained when they need to be because they are in mental crisis, both for their safety and indeed for other people. And as others have said, it's a long time coming, and I very much congratulate the Government for bringing it forward so early in their term. I, unlike just about everybody else in this debate, am not an expert in the field, nor do I have scars on my back from the considerations of the legislation in the past. I come to it as someone with lived experience of the impacts of the most deadly of all the mental health conditions, that of eating disorders. And in the context of this bill, as the mother of a daughter who was sectioned age 17, and I know that sectioning is hard. It is hard for the individual. They are separated from their loved ones. They are separated from the people around that they care. They can't do what they want. They're not where they want to be. And it's hard for families and loved ones who are trying to navigate the system. But I know that sectioning works. It saves lives. It saved my daughter's life when she was in the grips of an extremely vicious eating disorder, and she was so malnourished. She couldn't even allow anyone to feed her by a nasogastric tube. And the state had to step in and save her life. And she went to a hospital over 100 miles away and was initially restrained and was kept there for 5 months. And we visited her and they kept her safe. And at the end of those 5 months, we were able to bring her home, and she was able then to be treated in the community by the NHS team. And we are grateful for that care. So as I say, I know detention works, but as Baroness Watkins rightly said, we would need less of that detention if there were more provision of community services all around the country so that people could be treated quickly and appropriately. And we know that will require more funding, and that was a point that Lord Adeboali raised very well. It will require a bigger workforce, and it will require those community services to support people when they need it. But it will also need more specialist beds, and in the field of eating disorders, they are particularly needed. At the moment, there is only 251 beds in our country in the NHS and 198 in the independent sector of specialist adult eating disorder services. And this bill, which covers England and Wales, there are no beds at all in Wales, none. And yet we know they are absolutely needed, and Beat, the leading charity for eating disorders, estimates that about 1.25 million people in this country have an eating disorder. Mental health eating disorder services are absolutely up to the gunnels and beyond. And since 2010, the amount of hospital admissions for eating disorders has quadrupled, from 7,000 up to 28,000. So there is a real pressure point. And when my daughter Rose needed an eating disorder bed, there wasn't one available. So she was kept for a month on an adult general ward in the local hospital, where her condition deteriorated to the extent that she had to be sectioned. So we need more of these beds, and it is no good if we just spend all our time in this chamber focusing on the particulars of this very small but important part of the mental health bill in terms of detentions, if the government doesn't also grasp the nettle about the need for more beds for people when they really, really need them. And the other worrying aspect about not having beds is that it's actually stopping the mental health law being applied in the first place. I mean, the 1983 Act insists that local areas make arrangements for bed in urgent circumstances. But I was talking to the chair of the eating disorder faculty at the Royal College of Psychiatrists, and Dr. Ashish Kumar told me, sorry, for the record, just so that people know his name, Dr. Ashish Kumar told me, even after 2 medical recommendations, clinicians are not allowed to apply the section because the Tier 4 inpatient unit services do not offer them a bed. Hence, this is a silent crisis where these seriously unwell patients are not admitted to psychiatry wards or given the opportunity to have a legal provision of the Mental Health Act applied. The whole legal provision is disregarded in a very high number of cases. Therefore, I would ask the Minister, in summing up today, if she could reassure us, and I'm sure through committee, that the government will be putting equal focus on ensuring there is community provision for people with eating disorders to minimise the need for people to have to go into beds, but that there will always be sufficient beds for those people with severe eating disorders who really do need it. And the other point that I just did want to touch on, as I said, I agree very much with the comments of Lord Adeboali about community treatment orders, and it pains me to disagree with Baroness Browning, who I have the highest regard for, and it also pains me to disagree with Mind, because when we were facing Rose being sectioned, the place we turned to for the advice to actually understand the Mental Health Act, as parents literally pushed into it, was Mind and their fantastic website, and I pay tribute to them for that. But I believe that for eating disorders, community treatment orders can be very, very beneficial. If you are sectioned for an eating disorder, it is because your condition, your condition is such that you are at risk. When you come to be released, you are at high risk, even if you have community support, of losing weight quickly and facing an urgent readmission. That is because the complexity and the tyranny of the eating disorder means that the person can't, of their own volition, maintain their weight. What a community treatment order does is it puts a boundary around the eating disorder in a way that a voluntary agreement couldn't do, in that it makes it clear what will be the result, what will result in an inpatient setting. And eating disorders are a really complex battle of control. The person with an eating disorder feels that they're completely out of control, but they're desperate for control. And what a community treatment order does is it gives them control by not keeping them in a hospital, but also gives them some sense of control through the actual terms of the order, that they know what's going to happen. And let's not forget, it also gives some control to the community treatment team, who don't have to then wait for a medical emergency in order to readmit if that is needed. So I would contend that if it's done in the right way, if it's done in an open and consultative manner, with the intention of supporting that person to live in the community and access their community care, that a community treatment order can be uniquely beneficial for people with eating disorders. And I would contend it has the benefit of keeping that person out of hospital, and the restriction is on the eating disorder and not on the person. And I hope throughout the process of committee to carry on making the case for people with eating disorders and their carers alongside the many other experts in this field, so that we can ensure that this welcome bill is as good as it needs to be.
My Lords, I am grateful for the opportunity to participate in this debate, and I declare an interest as a retired psychiatrist and Fellow of the Royal College of Psychiatry. So much of what I will say comes from my experience of working as a consultant psychiatrist in Northern Ireland. And that is very particularly important because the legislation in Northern Ireland has always been different from the legislation on this side of the water. The 1950s legislation was referred to earlier on, but in Northern Ireland the 1961 Act, for example, did not permit admission, detention on the basis of personality disorder. And I'm going to come to that in a minute, because that foundational difference is of enormous importance. I welcome this bill, not because it's a perfect bill, not even because the foundations of the bill are particularly good, but because it's at least improvement on the way things have been for some time. I welcome the 4 principles that are identified: choice and autonomy, least restrictive approach, and, of course, therapeutic benefit, though that's a difficult one to assess in a short period of time, as Lord Adeboali has pointed out. It can be very difficult to work out whether particular approaches to treatment are going to work in the short term. Very often we need time, and treating the person as an individual, though again that's not as straightforward as it might appear. Because, as Professor Larry Smith, the President of the Royal College, has pointed out, there are ways in which a piece of legislation like this can be introduced that, although with plenty of resources you would get a good outcome, if you don't have adequate resources, you can actually make the situation much worse. Not just not enough resources doesn't make it sufficiently better, it can actually make it worse. Let me say 1 or 2 of the reasons why that is. For example, if there's a decision made to not admit the most seriously ill patients to hospital, a very good principle, what's the consequence of that? Well, the consequence is that the people who are in the wards are even more disturbed and much more difficult to handle. And if you simply keep the same level of staff, it's impossible to manage, because that number of staff is not sufficient to deal with an increasingly toxic and non-therapeutic environment. Or take the question of changing from the most direct family member to a nominated person. Very good, entirely support that. But it's not without its consequences. If the person is living before admission with the family and they decide to choose someone that is outside of the family may not be prepared to accept them back again, and the nominated person may not be in a position to accept them either. Because the truth of it is, none of us are simply individuals. We exist in the context of relationships. And if we don't find ways of engaging with those relationships, then simply operating on the basis of individual autonomy and human rights may actually create problems of its own. I absolutely agree that we should not be admitting disturbed people to police cells or to prisons. But if we don't provide sufficient alternative resources, then what happens is that either they are admitted to psychiatric units and other people who should be in those psychiatric units are unable to be admitted because there's no room left, or they're not actually admitted at all, and things just become worse. So it's a very complex issue. It's not at all simple. And there are unintended consequences. A whole list of colleagues have pointed this out. Baroness Murphy, Baroness Hollands, Baroness Buscombe, the Right Reverend the Bishop of London, Baroness May of Maidenhead. Almost anyone who's actually had direct engagement with the care of patients in these circumstances realises there's a degree of complexity about dealing with them that a piece of legislation on its own will not resolve, especially if it is not legislation that requires the provision of resources. And of course this doesn't. So you can not only not be successful if you do something without resources, you can actually make the situation worse. Are there better ways of dealing with this? Well, yes, my lords, there are. The Northern Ireland legislation is much better. It is what is referred to earlier on as fusion legislation. That is to say that it looks at the question of whether or not this person has actually a disturbance of mind and brain function, and secondly, whether they understand the information relevant to decisions and appreciate the relevance of that. So, for example, a person who had delusional thinking would obviously not understand the relevance and appreciation of it. But it gets us away from lots and lots of the problems that this part of the country finds itself dealing with because of the separation of mental illness and mental capacity. And those two things were brought together in the Northern Ireland legislation, which was easier because, as I said earlier on, personality disorder was never regarded as an appropriate basis for a formal admission in the first place. And as has been said by a number of colleagues, one of the difficulties you find yourself dealing with when you start to change legislation, if you don't fundamentally change it, and frankly, even if you do, is you're operating into a culture through which all the staff have been working for decades. And trying to change that is really very difficult. Now, one way of doing it is to take little steps. And I regard the step of separating out autism and learning disability as a very positive step in the right direction. Because the noble lady, Baroness Fox, is not in her place, but I actually agree, perhaps unusually for me, I agree with quite a lot of what she says about the over-medicalisation of problems of living. And it's true in the universities, where there's huge problems now about dealing with students. It's true in all sorts of areas, that every time someone has problems of living, it's mental illness, or actually it's, I've got mental health, doctor. The problem is we wish they did have mental health. That's what they don't have, which is why they're in a problem. But all sorts of problems of living are now thought of as disturbance and disorder. And that's in my view, that's a really serious mistake. And I have to say, psychiatrists have made their own contribution to developing things in that way. But we've got to pull back and look at it again. And that's one of a number of very good reasons, which have been pointed out by Noble Lords, why taking autism and learning disability out of that kind of package and seeing it in a different kind of way is, in my view, an important step in the right direction. But I come back to it again, as long as there is appropriate provision of resources. Because, again, without that, things are not going to go well, and we will have unintended consequences. Because those that have produced this legislation and those that have scrutinised it have done it with the best will in the world. They want to make things better. They're doing their best. But there's a funny thing happens in science. You produce a theory, you do some work with it, and then you discover it doesn't quite cover this issue. So you put in a little caveat. And then it doesn't cover that issue, so you put in another little caveat. And more, and the whole thing becomes more and more complex until suddenly one day somebody says, you know what? This is not the right theory. And there's a shift in understanding to a whole new way of thinking about it. And I think that actually that's where we are with problems of this kind. We're at the point where we really need to make a paradigm shift. And you would expect me to say it, but I think on this particular issue, the approach that's been taken in the place that I was working, in Northern Ireland, is a useful thing to explore. Just as it's bringing together of health and social care is, I think, a useful thing to explore. I think similarly with this. There are, of course, other useful things, like the advanced choice. But there are so many of them that we couldn't possibly deal with them in one debate. And that's why we will be discussing them for quite some time.
My Lords, I'm glad to take part in this debate in your Lordship's House after 4 years as a Shadow Minister for Mental Health and 6 years on the Health Select Committee in the Commons. In welcoming the second reading of this bill today, I want to speak about dealing with the inappropriate detention of autistic people and people with learning disabilities in mental health hospitals. Noble Lords, including those who served on the Joint Committee on the Draft Mental Health Bill, understand that too many autistic people and people with learning disabilities have been detained in inappropriate facilities and for far too long. But we as politicians and legislators have not made the changes needed to stop this. The Winterbourne View scandal and a series of other scandals since 2010 have shown abusive treatment meted out to autistic people and people with learning disabilities detained in inappropriate units. In 2011, following the shocking revelations made by journalists of the abuse to residents detained in Winterbourne View, which was rightly described as torture, the then Prime Minister pledged to close all inappropriate inpatient units by 2014. But that didn't happen. Since then, successive governments have also committed to targets to reduce the number of autistic people and people with learning disabilities in inpatient settings and to prioritise housing and support in the community for those individuals. But these targets have all been missed. In 2021, the Commons Health and Social Care Select Committee, of which I was a member, completed an inquiry into this treatment. Commenting on the missed and delayed policy targets, the inquiry report suggested a more radical approach was needed to unlock community provision for this group of people. Now there is a chance for reform, but there are widespread concerns to raise with my noble friend the Minister that the measures in the Mental Health Bill will not be enough in themselves. While it is welcome that the bill makes it harder to detain a person under the Mental Health Act on the grounds of autism or learning disability, there are widespread concerns, as we've heard in this debate, that this could lead to people being held under alternative routes, including the Mental Capacity Act 2005 deprivation of liberty safeguards. And we must guard against that happening. In many cases, autistic people and people with learning disabilities are not being detained just because of the legal framework they are under. They get stuck for years in mental health hospitals because of the lack of support for them in the community. In too many cases, discharge planning is repeatedly delayed because those responsible see the needs involved as too complex or feel there are no suitable care providers. And I want to mention two cases to illustrate this, the case of a young autistic woman called Bethany and the case of Tony Hickmott. When I first raised Bethany's case in the Commons, she was a 17-year-old autistic woman with extreme anxiety being kept in seclusion in St Andrew's Hospital, Northamptonshire, in a cell-like room and fed through a hatch in a metal door. When her father, Jeremy, visited her, he had to kneel at the hatch in the door to speak to her. Bethany was detained and held in seclusion despite an assessment that the hospital setting she was in could not meet her needs and a recommendation that she be moved to a community residential setting with high support. Now, the lack of funding for supporting the community was clearly a factor. The Walsall Council officer responsible for her placement had told Bethany's father that her care had already cost the council £1.2 million, and to be frank, the officer said to him, Walsall could do with a breather. Moving Bethany to a community setting would involve her local council paying £100,000 to £200,000 a year from the adult social care budget, instead of leaving the NHS to pay the much higher bill, which was £676,000 a year. It seemed that Bethany was being held in isolation so that the local council responsible did not have to pay her costs, but the very high costs of her detention were then borne by NHS England. I raised Bethany's case numerous times in the Commons and she was at last discharged to live in the community. Fast forward 7 years and her father talks about what a happy life his daughter has now in her own property with good support from a wonderful care team. But the outcome has not been as positive for Tony Hickmott, an autistic man with learning disabilities. In 2022, Tony had spent 21 years in a secure assessment and treatment unit, and it looked as if he could finally move back to his hometown of Brighton, close to his parents, Pam and Roy. Tony had stopped meeting the criteria for being detained in a psychiatric hospital in 2013, but it was ruled that he could not be discharged from there because a suitable community placement could not be found for him. His parents applied to the Court of Protection in 2019, and after a number of hearings, the judge ruled that Tony should be discharged from hospital to live in a specially renovated house with care from a brought-in provider. Now, this should have been a happy ending too, but it's not, because reports now describe that Tony is effectively barricaded into the bedroom with the care staff in his home operating the house like a seclusion room. Tony's parents, who are now in their 80s, are prohibited from taking him out into the community. He is held under the deprivation of liberty safeguards, and I do hope that Tony Hickmott's care provision can be improved. Now, much could have been done by governments over the last 12 years to tackle this issue of inappropriate detention. The new government has the chance to change this. Firstly, we must act to prevent new inappropriate admissions of autistic people and people with learning disabilities. Secondly, we must act to enable the discharge of the 2,000 autistic people and people with learning disabilities detained inappropriately in mental health units. And as we've heard in this debate, the average length of detention for this group is 5.4 years, with 355 people detained for more than 10 years. MENCAP have estimated the cost of this care in inappropriate units for this group as £534 million a year. Detentions are often, as we've heard in this debate, far away from family and friends, with alarming reports of people from this group being over-medicalised, subject to physical restraint and shut away in isolation. And all this is traumatic for those detained, as it's devastating for their families. And as MENCAP have said, their findings on the staggering cost of institutional care show that this is an appalling waste of public money on the wrong type of care. And I hope there's a will to change that now. As I mentioned, so first there's the issue of ensuring no new placements of autistic people and people with learning disabilities in those inappropriate mental health units. And the Commons Select Committee inquiry report made recommendations on how this could be achieved. Secondly, the issue of who is paying for care and community support must be tackled. And I do support the plan made by the plea made by Baroness Hollins for an action plan to actually succeed the Building the Right Support Action Plan. The Commons Select Committee inquiry recommended that the Department of Health and Social Care should redesign financial incentives so that local authorities and local NHS bodies do not seek to offload the care of autistic people and people with learning disabilities onto NHS England by placing them in inpatient facilities. But tackling these issues of funding flows now needs strong cross-governmental action. There are some further actions that could be taken to improve the mechanisms around this area of work, and I thank the human rights lawyer, Dr. Oliver Lewis, for his input. Currently, mental health tribunals are not considered useful in dealing with people stuck in hospital inpatient units. So tribunals dealing with cases for this group should be required to have a medical member with expertise in autism and learning disabilities. Working through the practical issues of achieving a discharge destination for people currently detained could be improved if either the Mental Health Tribunal would be given the power to compel a local authority or NHS body to find a discharge destination, or if the Court of Protection was used more to rule on discharge arrangements. Finally, this bill presents an opportunity to correct an oversight under Section 73 of the Care Act 2014 affecting human rights, which the noble lady Baroness Barker raised earlier. And I also thank Dr. Lucy Series and Professor Luke Clemens for information about the issues raised in the Samut judgment. As we have heard, that's a ruling that means that Human Rights Act does not apply when mental health patients get Section 117 aftercare in private settings. And there's a real concern about broader implications. Patients receiving continuing health care through private services, children in private social care, and even detained patients in private hospitals under the deprivation of liberty safeguards. This latter group could expand if the numbers of learning disabled and autistic people who are detained under the deprivation of liberty safeguards because they're no longer eligible for Section 3 Mental Health Act detention. My Lords, I'm sure it was Parliament's intention to protect the human rights of vulnerable adults and children for whom the state arranges health and care services. I hope my noble friend the Minister will agree to the suggested meeting with Lucy Series and Luke Clemens to discuss that. And I hope that we can bring forward amendments as necessary to correct this oversight, as well as to address the other issues I have raised.
I too welcome this bill. It's overdue, and times have changed, and people's views and sentiments and our knowledge have changed over those years. So I welcome the principles that are seeking to rebalance the way we handle these issues. All of this is in the context of a bill that is actually about the safety of service users as well as public safety. I want to come back to the safety of service users, but very briefly on public safety, I note that the barrier for detention will be higher. There must be evidence that serious harm may be caused to the health and safety of the patient or another person. The question obviously is what counts as evidence? Where is the place for the judgment of experienced clinicians? Is that evidence? Is the testimony of relatives? What's the definition of serious harm? I do understand the need for transparency, but this is a very difficult area that will obviously need much more discussion, I think, at later stages of the bill. I also welcome the separation out of the care for people with learning disabilities and autistic people and the needs of people in the criminal justice system, and of course the importance of tackling racial disparities. We've had a lot of impressive briefings, I thought, for this bill, and I just want to quote one of them actually, which is Blooming Change, I think it's called, which was the one about children who'd had experience of the system. And there are lots of issues here about patient safety and quality. They talk about being injured during restraint, just being drugged and restrained, being scared all the time. And there's a dreadful statement, that sentence there, which I'll read out, which is, hospital makes you worse. Going into hospitals with one problem and then leaving with trauma, new behaviours, new diagnoses, assaults, PTSD, it's awful. Now, I noted the earlier comments by the Noble Lord Earl Howe about the very large number, which I forget, was it 52,000 uses of restrictive interventions in the last year, and the comments of the Noble Lady Baroness Watkins about this, and the importance of it not being in adult wards. But it seems to me this is a great example of what we just heard from Noble Lord Alderdice about admission making the situation worse. The idea was to put people into a ward, but actually it led to a deterioration of their condition. If I think about the Mental Health Act, I understand why the review that a lot of this was based on was focused, but actually we can't think about the Mental Health Act in a vacuum. And let me just pick up 2 or 3 examples of that. First one is actually the very same Sir Simon Wesley asked me 10 years ago to look at the capacity of acute wards across the acute adult wards across England. And I did so, and with a group, we're in contact with every service in England and with consultants who were leading the admission and discharge of patients. And one of the interesting findings of that was that something over 20% on average of discharges were delayed because of housing. And indeed, of all those units in England, only 2 had any links with the housing authorities. I mean, this seems to me to be a very fundamental point. You've been stuck in hospital, you may well lose your accommodation and lead on to other problems. So that's just one example of many wider social issues that need to be taken into account, even though we're focusing on something as narrow as the terms of the Mental Health Act. There's also the impact on A&E, which the Noble Baroness Barker and Noble Lord Earl Howe have referred to very early on, about just shifting the problem, if we're not careful, from shifting it from one place to actually landing it up in A&E, where there may not be liaison psychiatry or anything else that will help with the problem. Now, a number of Noble Lords have deplored the lack of a wider bill in which this would actually nest. But it's very clear this needs to be implemented in the context and alongside other changes that are already underway. And there are some profound questions here, I think, about care and treatment, which, I mean, we've been very privileged, I think, to hear from a lot of people who know a great deal about this, including a number of very distinguished senior clinicians who can give us insight, as well as parents, of course, who can give us remarkable insight and profound comments. But if you look at some of the statistics, healthy life expectancy for all of us has improved massively over the last 40 years. But the gap between life expectancy of those with severe mental illnesses and those, the rest of us, has doubled since the 1980s and is now 20 years behind. If we also look at some other evidence, the NHS Independent Mental Health Task Force argues that outcomes from severe mental health problems have worsened in recent years, and others have argued that actually they've flatlined for about 40 years, and that in some cases have deteriorated. Now, various Noble Lords have talked about the sort of importance of the change in the model that we're talking about here, with much more focus in the community, much more focus on prevention, much more focus in thinking of this end-to-end, rather than just as isolated incidents involving isolated patients who don't have relationships with the rest of the world in that sort of model. And it really seems to be fundamental that we get hold of those issues. Even if it's not in this Act, they need to be linked into an understanding that those changes may well come with the forthcoming 10-year plan and the implementation of those. I would also just touch on something that a wider point about over-medicalisation of common problems. Another statistic, last year, finishing in April this year, 8.7 million people received anti-depression tablets. 8.7 million people, and that's just England, without counting anywhere else. And the major problem in that area, apart from the overprescribing itself, is actually helping people get off those drugs in due course. Another example of where some of our current practices have been doing harm within this. So we need a new emphasis on some of the social interventions that many Noble Lords have mentioned, and I think a new emphasis on patient safety. And finally, whilst this is not legislation, this is legislation, and it's only legislation, it does need to be accompanied with a real implementation plan for the management of change, because it can't be treated in isolation. These other moves and other leaders are making change and making change happen elsewhere. So very much welcome the bill, and very much look forward to having some discussions about some of these important issues as we move on into committee stage and beyond.
My Lords, it was a privilege to sit on the Joint Committee to scrutinise the bill, but it was disturbing to see for how long the legislation has been failing patients, their families and clinicians. I do thank my noble friend Lady May, who's not in her place, for instituting the process and for clearly placing a focus on the disproportionality faced by racialised communities. There is, of course, much to commend the bill, such as the change in detention criteria, statutory care and treatment plans, but the bill could still be improved. The introduction of community treatment orders made a bad disproportionality situation even worse. The mental health fact sheet, along with the bill, says that black communities are 7 times more likely to have a CTO than their white counterparts, which is an improvement, though, on the evidence to the committee, which was, we were told it was up to 11 times, and the Parliamentary Office of Science and Technology research states it's up to 10 times. Whatever it is, it's too high. And if they are to remain, I do hope the noble lady, the Minister, will outline that proper research will be undertaken to understand what is causing this disproportionality. Whilst I welcome the changes to CTOs, I do stand by the Joint Committee recommendation that they should be abolished for Part 2 patients, so I stand with Mind on that. There's obviously differing opinions on this now, and I think it would be useful to take this back at committee stage, because this CTO issue is, because of disproportionality, of particular importance to certain communities. I agree, though, with the noble Lord Adibawali that we also heard about the informed research that advanced choice documents are known to reduce detentions and also to reduce medicalisation when someone is detained. So whilst I'm pleased to see the advanced choice document on the face of the bill, I do ask that His Majesty's Government would consider that there should be a right to request that. As the bill goes through Parliament, I do hope that the hard work of a smaller, often less resourced group of activists for these communities will be appreciated. The work of NAS and the MenCap is exemplary, but sometimes those who are not able to shout the loudest are actually in the greatest need of our support. And I am sad at this moment to notice that 2 of these provisions that are particularly important to racialised communities are being diluted. But one of the most important changes is that the outdated use of nearest relatives are being replaced by nominated persons who represent them and exercise relevant statutory functions. It's important, my lords, to note the power that the nominated person has. It includes the power to order the discharge of the patient, unless, of course, a barring order is named. Ideally, the nominated person is, of course, chosen by the patient, but if they don't have capacity, this function is done by the approved mental health practitioner, AMP. These are welcome changes for most adults, but I note the comments by the noble Lord Alderdice. But the Joint Committee's report highlights that all is not clear with regard to the nominated person and children and young people. The decision not to have a new piece of legislation is a particular problem. When the Mental Health Act 1983 was passed, it was only envisaged really it would apply to children in the criminal justice system. To complicate matters, the 1989 Children Act was passed, with further amendments later on, giving 16 and 17-year-olds the right to consent to medical treatment if they have capacity. Then came the Mental Capacity Act, which doesn't apply to under-16s, but does apply if you're 17. Then we had Gillick competence added to the mix. Yes, my lords, it's all rather fudgy, before you even add on the nominated person and the Act. So just a couple of examples. For the under-16s, under Schedule A1, the nominated person must be the person with parental responsibility. But what of the situation of a special guardianship arrangement, where the parents keep some residuary parental responsibility? Does the AMP have to appoint the parents and the special guardian? And that would set up quite a difficult arrangement for clinicians. Also, why does this schedule say that if the local authority is willing to act as the nominated person, under the Children Act, when there's a care order, they have a duty to act when they have parental responsibility? Turning to the 16 and 17-year-old who lacks capacity to appoint a nominated person, there's no mention at all of parental responsibility in Section 10 of that schedule, yet the young person might be living with them. So, if the nominated person uses the powers of discharge, a process takes place for them to be discharged, you're relying on the mental health institution to remember that parental responsibility lasts until they're 18 years old, and to tell the parents that they're on their way home. And that might sound not a problem, but if you've got other younger children in the household, it might be a risk to them to have that person back in the household. Also, a 16 or 17-year-old may be under a care order. Are the local authority going to be informed because they're going to be providing the accommodation? The schedule is silent on that. A common statutory mechanism is to mandate for particular circumstances like the under-16s, but to have a presumption for other situations. So why not have some kind of presumption that the 17-year-old persons with parental responsibility should be the nominated person if they're residing with them? The previous government accepted that after the independent review on children and young people, more thought needed to be given. So could my noble friend the Minister outline that could we have a meeting about children and young people with officials, Minister, interested peers, but also the experts in this field who are practising in this niche area of the Mental Health Act and the Children Act? The children and young people are also in a vulnerable position if they have learning disabilities and autism and no co-occurring mental health illness. If they are in crisis and the parents need help, if there's no Mental Health Act provision, then what happens? We've had the situation covered by the Noble Lady that about the use of dolls under the Mental Capacity Act. But if you are 17 or 18 and lack capacity and are held under that, but there's no Section 117 aftercare. But if you are under 16 or 17 with capacity, you're not under the Act at all. Where does that leave you? That probably leaves you under the inherent jurisdiction of the High Court, or rarely a care order. Only last week, the Children's Commissioner reported on around 1,000 children a year who are now under the jurisdiction of what's called a High Court Dole's order. Let's just say her report is not good news about that third provision to restrict your liberty. So whilst the situation for those with learning disabilities and autism is currently shocking, and I marvel at the work of the Noble Lady, Lady Hollins, the Act could make a bad situation worse. I think this would also be important to cover at the meeting that I have suggested, and that as High Court Doles, as they're known, is a relatively new creation, it would be good to have former judiciary who have had experience of imposing those orders on children and young people. Finally, I'm disappointed not to see the recommendation from the Joint Committee of a Mental Health Commissioner as part of the bill. Since the Joint Committee reported, rare events have shown the danger to the public if mental health services fail. Often it is those who are not medically trained but are friends and family who can see that someone's getting really unwell and they need help. Is it obvious to know where to go to? If you've tried the previous hospital, you try to use PALS, do friends and relatives really know that maybe it's CQC that you need to go to? And the police have rightly stepped back in some respects in these situations. My Lords, not appointing a mental health commissioner is a missed opportunity. It's imperative that those people know somewhere to go to. Whilst the Joint Committee's report was not overt about this being a function of the mental health commissioner, because it was before the events I've outlined, an emergency process like this could well fit within their remit. It would be a one-stop shop. Whilst there is a mental health homicide review underway, if there is the need to legislate, we could now be missing it. If His Majesty's Government puts forward a mental health commissioner, though, whose functions could be by way of secondary legislation, the door to legislation remains open if that review suggests such measures. Finally, my Lords, I do hope that the Noble Lady the Minister will be informing your Lordship's House that the Law Commission are being requested to look at whether in England and Wales we should be doing what the Noble Lord Alderdice recommended is happening in Northern Ireland, namely the fusing of our mental capacity and mental health laws. This is a sticking plaster only on an area of law that badly needs a restart.
Well done.
My Lords, I declare interest as Chair of University College London Hospitals NHS Trust, Whittington Health NHS Trust, and as a member of the North Central London Integrated Care Board. I'm absolutely delighted to be able to speak in support of this bill today. It's been a long time coming. As Noble Lords know, I was one of the 3 vice chairs of Simon Wesley's review, and it seems a long time from 2018 when we published that. And I do want to pay tribute particularly to the Noble Lady Baroness Buscombe and her team for the pre-legislative scrutiny, which did so much, if you like, to clarify and to push the draft legislation to nearer what our original review had said. But you won't be surprised to hear that there are still some areas of concern. And I say that as I pay tribute to the Noble Lady the Minister for all her engagement, both formal and informal, with members of the review team. The Government has published the impact assessment for the bill, showing what it believes will be the costs of the improvements we all wish to see happen. But it said absolutely nothing about how it's going to pay for all of this. And if we are going to make these reforms work, we are going to need money in the system. And other Noble Lords have said precisely that, notably the Noble Lord Alderdice and Baroness Watkins on the subject of staff in particular. You only have to speak to people working in this field to realise that they're desperate for resources, beds, staff, particularly nurses, alongside alternatives to detention that provide real care and do not leave people on the streets. And that goes back to the issue of community treatment orders, which we will come back to, no doubt, at committee, because this is a really serious concern. We all know that public finances are under huge pressure, but I do urge noble lords, and particularly the noble lady, the Minister, to push as hard as possible for funding for these reforms and the mental health system as a whole. It's really needed, and if we don't do that, then whatever we legislate will make precious little difference to what actually happens, and that's what we ought to worry about. It's also vital that this House notes the commentary from the Royal College of Psychiatrists, whose president, Dr. Lade Smith, warns us that these reforms must not make worse the racial disparities already associated with the use of the Act, and we do need to take heed of that, as many other noble lords have said. I want to thank some people in particular, notably Sir Simon Wesley, the chair of the review and, one might argue, the architect of these reforms, and my co-vice chairs, Mark Headley and Steve Gilbert, for their essential contributions. But I want to pay tribute to the civil service teams in the Department of Health and Social Care and in the Ministry of Justice, and particularly Matthew Lees, who put in huge amounts of hard work and showed astonishing devotion to the cause, and some of them have seen it all the way through. Now, we're delighted that the bill includes the new guiding principles that we devised and recommended, as well as legislation to promote the use of advanced choice documents. But as the noble Lord Earl Howe has said, and the noble lady Baroness Berridge, there is something very peculiar about the way this is framed, because advanced choice is not given as a right to patients. This is a duty upon the ICBs. I do think that when we get to the committee stage, we need to push that one quite hard. And we also remain disappointed that the government has not been able to include measures relating to our recommendation that the tribunal should consider appeals from patients where they've expressed a preference for a particular kind of treatment which has been overturned by doctors. We believe that that would be an uncommon occurrence, but nevertheless an important safeguard for patients' rights, and it's a right to be involved in decisions to do with your own care. I really hope that the government will reconsider this proposal, ideally before we end consideration of the bill. My Lords, we're living in a time of increasing tolerance and understanding of mental ill health and decreasing stigma surrounding it. But that's not what many people in the system experience. Many people are most distressed not by the detention itself, but by the way in which they're treated and made to feel helpless, ignored, and stripped of their dignity and self-worth. That's why the review identified, and I think this is really, really key to this, that's why the review identified a clear gap when it comes to supporting and valuing patient autonomy. And it's why we argued that we must move from what we heard all too often, that there's a default position of clinical staff rejecting what the patient wants. Many of the independent review's recommendations therefore aim to shift the dial in favour of greater respect for the wishes, choices and preferences of patients. And it was also clear that when people were rightly, in their own view, being deprived of their liberty, they were also all too often being deprived of any say in how they should be treated. As one service user who was part of our core team told us when we started on this process, "I am sure being detained saved my life, but did it have to be such a terrible experience?" In one significant respect, the bill goes beyond any recommendations that we made, proposing, in effect, to exclude learning disability and autism from the scope of the Act, except for short-term admission. Other noble lords around the House have spoken on that, but we were and remain concerned that exclusion from the scope of the Act might not solve, though it should, but instead simply shift the problem to elsewhere. And I think the noble Lord Alderdice, was actually hinting at that too. This bill, unlike its predecessors, and I am a veteran of 2008 as well, enters Parliament with a considerable level of agreement from all the political parties, professionals, media, the charitable sector and service user groups, and in particular stakeholders representing ethnic minority communities, though there are considerable worries. There are some concerns, and we know about that, and I very much hope that the noble lady, the Minister, will be able to meet once again with the teams from the Royal College of Psychiatrists, and indeed with some user groups, particularly those people with autism and other disorders, who are expressing major concerns to all of us, and all of us will have had some of those emails. And I hope that that can happen as the legislation goes through, to see if there can be any further fine-tuning. But this is without doubt the right time, or could one say even overdue, to modernise the Act, and I very much hope this House will support it.
My Lords, today I will focus on those aspects of the bill that concern children and young people with learning disabilities, autism or both, but I also want to note that listening to the noble lady Parmenton's lived experience I found very moving indeed. My formal interest in this dates from my being the independent chair for NHS England's Children and Young People's Transforming Care Steering Group for children and young people with autism and learning disabilities from 2017 to 20, and before that as chair and non-executive board member of various NHS organisations. My close personal interest, however, is lifelong, as the younger sister of Patricia, who I mentioned in my maiden speech. Patricia was born in a much less enlightened time than we enjoy now, with a learning disability which denied her expressive language and deemed her at the time of her early childhood in the 1950s as a mental defective under the then mental deficiency legislation. My brother Jim followed soon after. My younger sister and I came some years later, to our loving parents' great joy. But neither she nor I ever lived with my sister, Patricia, as she was taken away from our parents when she was 7, before we were born, to a huge and forbidding mental hospital near Birmingham, 3 long bus rides away from where our parents lived. They had to write each month to the hospital authorities for permission to visit, a maximum of once a month. When our father died in 1990, my mother asked me to become Patricia's co-guardian with her and gave me a box that he'd kept of all the paperwork concerning Patricia. The letters from my father asking for permission for Jim, my brother, to visit his sister once she was removed from the family home are heartbreaking to read, as he was always refused even at Christmas time because Jim was under 12, so he didn't see his sister for years. By the 60s, these rules had relaxed, and my other sister and I were taken one Sunday a month to visit. I dreaded those visits of the little girl, I'm ashamed to say. Not because of Patricia, who I liked to see and spend time with, but because of the part of the hospital was a forbidding Victorian building where patients with mental health issues were kept. Sometimes I would hear screams and see figures trying to put their arms out of the top of windows. And at the side of the hospital for the learning disabled, by then called mentally handicapped, physically a much pleasanter part of the site, we would sit and eat with and cuddle our sister, who was always delighted to see us, especially our mother. In time, my parents got a car, and my father would take us out to drive to a cafe with Patricia. Sometimes we were made welcome, and sometimes not so much. My sister never went to school, as she was 18 by the time the duty to educate children with learning disabilities came in, following the 1970 Act. My mother found that heartbreaking. As a child, I didn't know that my parents were campaigning to get her moved nearer home, hoping to take advantage of a more benign regime that was developing in the 1970s of long-stay campus-style hospitals, where young adults with learning difficulties could live, still under NHS care, but with fewer restrictions on the number of visits and more activities for patients' later residents. Eventually, my parents were successful, and those were happier years, with much more contact, and my sister being able to visit the home that she hadn't grown up in. After my father's death, I took up the campaigning mantle from him to make sure that Patricia genuinely benefited from the latest initiative, Care in the Community. And my sister lived her last years, until she died in 2018, in a real house near our family home with 3 ladies she'd been with previously, and we could visit whenever we wanted. My brother died 30 years ago, so he didn't live to see this, and me and my other sister had moved to London, but my mother was delighted, as were we, that she lived in a proper house with its own kitchen and home-cooked meals, and we could visit whenever we liked. So when the Noble Lord Stevens of Birmingham, in his previous role as Chief Executive of NHS England, asked me if I would establish and chair the steering group in support of transforming the care of children and young people with autism and learning disabilities, you can see why I jumped at the opportunity. As the chair of the steering group, my task was to help bring together all those organisations which had important roles to play in reducing the number of children and young people with autism, learning disabilities, mental health conditions and behaviours that challenged, but with no criminal background, being detained. The steering group included representatives from the Department of Health and Social Care, Department for Education, local government, as well as charities advocating for these children and young people. What became crystal clear was that detention happens when local education, health and children's social care services either do not or cannot meet their complex needs appropriately. And although the world has clearly moved on a long way from the days of my sister's incarceration, I'm afraid to say that I heard some very distressing accounts from families and indeed hospital staff of the reality of detention, as eloquently described by my noble friend, Lady Keeley. And also not so much short of enforced solitary confinement as described again so eloquently in the important work by the noble lady Baroness Hollins. At the same time, I saw inspiring examples of what is possible when local community services come together around the needs of children and young people, including on a visit to a special school in North London, where I saw pupils who in other circumstances would have been locked away in secure hospitals. The head teacher worked with a multidisciplinary team, including social workers, speech and language therapists, psychologists and others, who liaised closely with the pupils' families. One key issue that was raised repeatedly by families and those youngsters who could speak within themselves through the stakeholder engagement meetings we held was that although NHS guidance states that each child or young person should receive, in such a situation, receive a care, education and treatment review, CERT, and DFE guidance requires that they should also receive an education, health and care plan, an EHCP, this was all too often either not happening in a timely manner or was happening but not being acted upon. This was partly a matter of resources, partly a matter of priorities, and partly a lack of joined-up work between health, education and local government. The bill before us today includes proposals to strengthen current arrangements, and this is to be greatly welcomed. In particular, the assumption in this important bill that children and young people with autism and learning disabilities should not be detained if at all possible, and if this isn't possible, only for the minimum of time and with a proper review and plan for treatment in place, is a huge step forward. I am delighted that it has received wide support across the political parties, beginning with the noble lady Baroness May when Prime Minister and subsequently by more recent governments. It shows it begins to show that families like mine, in its attitude, society towards people with learning disabilities and autism, we're beginning to make real progress, albeit sometimes slower than we'd wish for, to greater understanding and humanity. But legislation on its own can only take us so far. Genuinely sustained improvement will require multi-agency work, including at government level, as my noble friend said, with high levels of cooperation in the community, providing effective support for children and young people at risk of being detained. Stronger multi-agency community services, combined with the provisions in this bill, would ensure a very different life for those children and young people and their families from the one my sister had.
Very powerful speech from Baroness Ramsey, which reminds us all of the personal stakes that we are debating, and indeed many other such speeches this evening. I started my NHS career about 30-odd years ago running a large psychiatric hospital outside Newcastle, where in some respects the quality of care was high, but in other respects, frankly, far too many people with long-term mental health problems had effectively been warehoused for decades. And that was a point in time when there was a big shift to re-provide services in less restrictive community settings. And the reason for mentioning that is simply just to remind us that it wasn't the 1983 Mental Health Act per se that triggered all of that. It was a combination of better therapies, alternative services, and frankly, greater power and influence for the voice of users of mental health services that together constituted that initial shift in services. And so as we think about the bill before us tonight, yes, of course, we must principally attend to the internal content of the proposed legislation, but we must also think about how fast it is going to be implemented and the context in which it will land. So in terms of the internal provisions, I think, as we've heard tonight, this is to be a very well-vetted piece of proposed legislation. We will want to pay attention to unintended consequences that various noble lords have raised this evening, and I agree with others that some components are seriously underpowered. The advanced choice documents provision, I'm afraid, won't cut it as currently described, and we've heard that from Baroness Buscombe, Baroness Barker, the Noble Earl Howe, and many others. Unlike the clinician checklists, which are set out as a requirement in Clause 11, or the care and treatment plans that are a statutory requirement in Clause 20, or the new rights for voluntary inpatients to access independent advocacy as set out in Clause 38. When it comes to the advanced choice documents, all we have is a fairly vague subjective responsibility on the NHS and integrated care boards to give it their best shot. I'm paraphrasing, but only slightly. Effectively, they're asked to provide information and help to the extent that they consider appropriate. So frankly, notice on a notice board with a phone number to call would constitute progress as far as the bill is concerned. So we need to, I think, fundamentally address this. And it sounds as if, based on the comments this evening, there may be a latent majority for an amendment when we get to report stage, depending on how debaters got through into committee. But that's just one example of the content of the bill itself. But the related question is the one that Lord Scriven, I thought, very powerfully also raised, which is, however good this is, when will it actually see the light of day? When will it be implemented? And actually, the most salient piece of this legislation there is lurking right at the back, Clause 53.3, which essentially says most of this stuff will only spring into life through the fiat of the Secretary of State at a date yet TBD. And as the impact assessment, which, again, as Lord Scriven says, is actually a very important and revealing document, says a lot of these measures are seriously backloaded, and even the ones that are supposedly front-loaded are highly dependent on a set of resourcing which may or may not occur. So, for example, the new detention criteria for people with learning disabilities and autistic people, there's a little asterisk. It said it may start in 26-27, but it says the timeline is highly indicative as an illustration for modelling purposes because the reform will commence once systems are able to demonstrate sufficient levels of community support for people with a learning disability and autistic people as an alternative to hospital-based care. Well, as we've heard from Barrett Keeley and others, we've been waiting for that for some long years. My concern is that we run the same risk here as we saw with, say, the implementation of the Dilnot reforms, which is something is sat there on the statute book but never actually comes to life because it's always manana when it comes to the chicken and egg problem of resourcing and alternative services to allow the thing to come about. So we've got an implementation timescale question I'm sure we'll want to pay attention to. And then related to that, of course, is the extent to which this bill interacts with the real-world state of mental health services, social care, housing, the criminal justice system, and so forth. And two of the four principles, in Clause 1, around choice and autonomy, least restrictive care, are intrinsically tied to the availability of alternative services. And you cannot, therefore, divorce this bill from decisions that this government and future governments will make on its resourcing. And if we want to kind of have a moment of legislative humility, cast our minds back to the 2012 Health and Social Care Act, where parity of esteem was legislated from the rooftops. And frankly, we did not see parity of esteem begin to kick in on the back of that declaration. In fact, what we saw between 2010 and 2016 was that at a time of rising mental health need, the mental health workforce was cut by 9.4%. I took the decision, with, I might say, the support of the noble lady Baroness May as Prime Minister, that from 2016 onwards we would introduce something called the Mental Health Investment Standard, whereby we required that each year the share of NHS funding going on mental health could not fall, had to be at least constant and should be rising, so as to stop the squeeze that was otherwise taking place. And as a result, in contrast with the 9.4% reduction in the mental health workforce from 2010 to 2016, since then we've seen a 26.5% increase. And as Lord Darcy said in his review for the new government, quote, "This important intervention has enabled much of the mental health capacity was cut in the first part of the 2010s to be rebuilt." And that is why this House in the 2022 Health Act was good enough to support my amendment, which was then adopted by the government, ensuring that prospectively, before the start of each financial year, the government of the day has to set out its stall, has to declare whether it intends that mental health spending will grow as a share of the overall pie in the year ahead. And the reason I think we can see that so important is not just history, but at a time when, understandably, there is going to be great political focus on waiting times for physical health, for routine operations. Absent that mental health investment standard, the most likely outcome is that it is mental health services that will get screwed at a time when other things are being prioritised. So I think we will want to see a renewed commitment by the new government to that mental health investment standard, perhaps as early as the planning guidance for the coming year, 25-26, which we will be able to take stock of when this bill actually comes before us to committee to make a judgment as to whether or not we should be recommending a strengthening of that mental health investment standard in the statute itself, because it is inconceivable that the good measures laid out in this bill can actually be implemented while mental health services are being squeezed as a share of the growing NHS budget. So look, in the movie The Magnificent Seven, the Western movie, I think it was Steve McQueen who said, as gunslingers, we deal in lead. And clearly, here in Parliament, we deal in law, but my underlying point is that law only gets you so far. The question is not just the content of the law, it's how it's implemented, how fast and in what context. And we need to keep our eyes on all of those as this bill proceeds.
My Lords, as the last backbench speaker in such a rich and informed debate, the fact that in the Green Group that each week we start at a meeting where we asked ourselves what original things do we have to say specifically as Greens about this bill or about this debate, it's really useful to have at this particular point in the circle, because I first of all want to say that as Greens we very much agree with, I think as virtually every noble lord has said, with the need for this bill, and we also very much agree with the need to strengthen this bill. I would, however, respectfully disagree with a number of noble lords who have suggested that we're seeing an over-medicalisation of life events, that we don't have, perhaps this wasn't quite what they meant to suggest, but it kind of came out sounding like it, that we don't have a mental health crisis in our society, because I would very much say that we do have a mental health crisis. I'd agree with the noble Lord, Lord Crisp, that there's a great need for more talking therapies, and that for want of those, medical professionals are very often forced to resort to pharma solutions, and we need those talking therapies, but we need treatments because we have a mental health crisis. And behind that is not any characteristic of individuals, but a deeply unhealthy society. And when we're thinking about this bill, we have to think about this bill in that context. And we have to think about the fact that when we compare ourselves to societies that we generally consider comparable, we have much greater health problems than other comparable societies have. And we have to ask ourselves the question why that is. And this is true of mental health and it's true of physical health, insofar as it makes any sense to make a division between those two. I don't think anyone has yet used this evening the phrase the gut-brain axis, but in the last decade there has been an explosion of understanding of the link between the microbiome and mental health. And we have, particularly in the UK, a broken food system. Now, this is, of course, a long way from the legislation in this bill, but it's the context. If we're going to think systemically, it's the context in which we have to think about this bill. And, of course, there's also the social issues. Some noble lords have made some reference to this. The levels of poverty, the levels of insecurity of income, insecurity of housing, jobs that actually make workers ill from the pressure, the way in which they are treated as though they were robots, that make people ill. We have a loneliness epidemic, and I don't think anyone has mentioned that yet this evening, but that is very much related to our mental health epidemic. We have a huge problem with domestic violence, which is also related to mental ill health, particularly among the victims who suffer as a result. We need to take a public health approach to mental health, and whilst that's not directly part of this bill, we really cannot talk about mental health without talking about all of those issues. In terms of another couple of areas in which the Greens take a unique approach to the mental health issues, we do not believe that the coercive power of the state, which is what this bill is talking about, should ever be put into private hands, and we do not believe that healthcare should ever be run on a for-profit basis. And I'll pick out here the points made by the noble lady Baroness Keeley about some areas in which private provision of mental health care has gone horribly wrong. And thirdly, I would point out a number of noble lords have focused on the problem of stigma and the way in which perhaps we have made progress over recent decades, but we still have a great deal of progress to go. And I would very much say that we have to think very carefully. Some very senior people in our society have to think very carefully about using rhetoric of strivers versus skivers, and a suggestion that all we have to do is get these people into a job and then they'll be fine. Because that is the underlying message we are hearing from certain very senior quarters. And I think I have to make a mention of the fact that there's been talk of combining support for people seeking jobs and mental health care. I wouldn't necessarily say don't do that, but I would say that has to be done with extreme caution to ensure that this is not something that puts more pressure and stress on people and interferes with them becoming well. Now, I do want to perhaps more positively both commend the government for bringing this bill forward very early in its term, and also to commend the government for making this a bill that starts in the House of Lords. Because I think the comparison that I would make is with the domestic abuse bill, which quite a number of noble lords who've taken part in this debate also took part in. And I think there was a genuine cooperative effort from all sides of the House to make that bill better. And I think it's been very clear this evening that there is the same desire in this chamber. And I think many noble lords have made the point about the need to actually resource what's in this bill. And that was also what we were saying in the domestic abuse bill. I'll single out a few, Lord Alderdice, Lord Aberdawawe and many others. And I think there's also been some really good ideas come up in this debate, and I'm going to particularly single out the noble lady Baroness Watkins. The idea of a safe staffing level for community services, to me, strikes me as a really, really potentially transformative idea that is really essential. Far too often care in the community has simply meant being abandoned in the community and being left in the hands of horribly overworked staff who are then subject to abuse and questioning when things go wrong because they simply have not been able to handle the workload through no fault of their own. And it's really crucial that we tackle those issues. So I'm going to very quickly whiz through some specific points of the bill, particularly focusing on things that other people have not said. And I haven't heard a great deal of discussion of the idea, as recommended by the Joint Committee on the Draft Mental Health Bill, that we have a mental health commissioner. And the briefing from the Centre on Mental Health draws a parallel with the powerful impact of the Children's Commissioners. I would also add the impact for the Patient Safety Commissioner, with which I worked with the noble lady Baroness Cumberledge over many years, and again was a case where your Lordship's House was very powerful in pushing to create that position. and that having that patient safety commissioner has made a real difference. And I think having a new statutory role to champion mental health across government and speak up for people with mental health illness was something we really should be including in this bill. Very briefly, I'm going to agree with the Noble Lady Baroness Fox on the community treatment orders. This bill still allows these to be continue indefinitely rather than placing a time limit on it, with an option for a new one if needed. These should not be renewed without proof of necessity and proportionality. And I particularly want to take my remaining time to focus on the importance of children and young people, and many other noble lords have addressed and given us statistics on how our mental health services are really failing young people. And I want to draw another parallel with another element of what the government's doing, and which I have praised, which is a couple of nights ago, rather late in your lordship's house, about this sort of time actually, we were discussing the government's plan for a new youth strategy, and their plan to make sure that there's really strong consultation with young people about that youth strategy. What I would ask, the one direct question I'll put to the Noble Lady the Minister is, I'm sure the Noble Lady is aware of the phrase, nothing about us without us. What is being done to ensure that there is a real say for young people, particularly young people with experience of the mental health system, to ensure that they actually have the chance to be involved in this bill? And one final technical point to rush into, the bill introduced the new statutory care and treatment plans for all patients. That's welcome, but many under 18s are admitted under an informal basis, so won't be covered by this. So how is that going to be dealt with? And finally, one final rush-in point. Lord Alderdice and others have talked about how we can learn from other parts of the UK. The Mental Health Act in Wales has a measure to give people the right to have a mental health assessment if they request help. That is surely something that we could learn from and include in this bill.
My Lords, I apologise for my croaky voice. It's been an excellent and very well-informed debate, and like all other noble lords today, I welcome the early introduction of this bill after so many years of delay to modernise the woefully out-of-date 1983 legislative framework. Indeed, I think it's been one of the longest and most tortuous gestation periods of any piece of legislation I can remember. I thank so many organisations for the excellent briefings I've received, as well as those who've worked so hard to get us to this stage, including the independent review chaired by Sir Simon Wesley and the cross-party joint committee chaired by the Noble Lady Baroness Buscombe. My Lords, those people directly affected by this piece of amending legislation deserve better. From these benches, we welcome the introduction of the Mental Health Bill as an important step towards modernising the mental health care system and enhancing patient rights. We're encouraged by the bill's emphasis on empowering patients and giving them greater control over their treatment decisions. I want to firmly establish the principle that detention is an opportunity for treatment and a path to recovery, rather than being seen as solely in terms of containment. Like so many others, I particularly welcome the fact that the bill seeks to limit detention for people with learning disabilities and autistic people who do not have a occurring mental health condition, and removes prisons and police cells as suitable places of safety. And as my noble friends Lord Scriven and Lord Alderdice have both said, this reform package moves incrementally in the right direction, seeking to balance the rights of the individuals with the imperative of public safety. But, my Lords, there is much more to do to strengthen and improve the bill, and to look at the wider context, particularly at the adequacy of existing mental health services outside of the Act and broader social inequalities. Ensuring we have the necessary funding, the workforce with the right skills in the right place and the right training in place will all fundamentally affect the implementation of this bill. However, I am disappointed that quite a number of the recommendations by the Joint Committee have not been picked up, particularly the Mental Health Commissioner, the interface between the Mental Capacity Act and this bill, and strengthening duties for integrated care boards and local authorities to ensure an adequate supply of community services for people with learning disabilities and autism, points to which I shall return. So could I ask the Noble Lady the Minister if the Government will provide a detailed response to the Joint Committee report, setting out the rationale for the recommendations that have been accepted and those that haven't. My Lords, there are a number of themes we will want to explore at committee stage. Firstly, prevention. We all know that in healthcare, prevention is better than cure. Indeed, Lord Darcy, Wes Streeting and the Prime Minister have all said it as one of the big three transformational shifts needed. So we need to apply that same principle to this bill and live up to that mantra. Put simply, we need to focus on preventing people from reaching the point where they risk being sectioned in the first place. That means deeper and wider preventative mental health in our communities. Currently, as a country, we focus on treatment rather than prevention. We spend around $230 billion on healthcare, but only $3.5 billion on public health, and only about 3% of that on preventative public mental health work. There's so much more we could do in schools, walk-in hubs in the community, regular mental health check-ups, etc. So a key Liberal Democrat objective in this bill will be promoting good mental health, and I believe we need a power included in the bill that would enable the relevant health and local authorities to undertake the promotion of mental health with realistic resources attached. It's also why I want to see a new right to both assessment and treatment for mental health introduced, similar to the Care Act rights we introduced back in 2014, for people to get the help they need at earlier stages, directly preventing unnecessary admissions. On racial disparities, my Lords, given that two of the key drivers of the 2018 review were to reduce retention rates and the stark disparities in the application of the Act on some racial groups, as both the Noble Lady Baroness May and the Noble Lady Baroness Berridge have said so powerfully, we must explore what other opportunities exist to strengthen legislation in this regard. And specific examples, I think, would be putting the patient and carer race equalities framework on a statutory footing and including an additional principle, the equity principle, to the existing four guiding principles, which, like Noble Lords Lord Bradley and my noble friend Lord Scriven, I would like to see on the face of the bill to underline that they sit at the heart of all decision-making covered by the bill. I also support a new responsible person role at hospital level to oversee and monitor race equality in the day-to-day operation of the Act, with a corresponding duty on the Secretary of State to report annually on progress against reducing inequalities. My Lords, such a package could have real teeth. Like the Noble Lord Bradley and others, I also strongly support the establishment of a mental health commissioner, as recommended by the Joint Committee. Such a commissioner, I think, could both promote access to treatment across the spectrum of mental health services, including things like beds for eating disorders, and oversee implementation of the Act, including ensuring that racial disparities are fully addressed and monitoring the use of community treatment orders. My Lords, in terms of seeing detention as an opportunity for treatment and recovery, I would like to see the definition of appropriate medical treatment strengthened to take account of the settings in which treatment is delivered, including community settings, and the importance of non-drug-based interventions, either in tandem with medication or on its own, where clinically effective. On CTOs, as many noble lords have said, the bill makes some important changes to better regulate the use of CTOs, originally meant to be a route out of disproportionate sectioning, but which in reality have exacerbated the number of black people being subject to compulsion under the Act. However, the revisions in the bill currently stop well short of adopting all of the independent review's recommendations. For example, it allows CTOs to continue indefinitely rather than placing a time limit on each CTO with the option to make a new one if still needed. We really, I think, as the noble my noble friend Lady Parmenter made clear, explore this at committee. And as many have said, I believe we need to view equal treatment between Part 2 and Part 3 patients of this as paramount, ensuring that all patients detained under the Mental Health Act, including those involved in the criminal justice system, have equal access to advocacy, to mental health tribunals, appeals and other rights, no matter which part of the Act they are detained under, is a key principle for me. And given, as I've said, that one of the key drivers of reform was addressing racial inequalities, and that black people are significantly more likely than white people to be detained under Part 3, we currently risk further entrenching these disparities. My Lords, much has been said rightly about people with learning disabilities and autism, and the changes to Clause 3 are an important step in ending the human rights scandal of inappropriate detentions for autistic people and people with a learning disability. And I think, as the Noble Lord Tuig and the Noble Lady Baroness Hollins said, legislative change must be accompanied by investment in the right community support. Without this, autistic and people with learning disabilities will continue to reach crisis point with their mental health. And there's a real risk of these groups falling into the criminal justice system simply due to lack of community provision, as experienced in New Zealand, I think, as the Noble Lady Baroness Watkins highlighted, and then being unable to access Section 117 aftercare support. We are told that this change will only be enacted once sufficient provision is in place. So could the Noble Lady the Minister provide more details on how this decision will be taken and what the government will do to ensure that capacity is being built up in the community? My Lords, we also heard concerns from my noble friend Baroness Barker and Lord Bradley and others about the interface between this legislation and the Mental Capacity Act. I share those concerns. I feel it is currently very fuzzy and unclear, leading to inconsistency in practice and confusion as to which legal framework applies. We must explore this further at committee, including understanding what's happened to the liberty protection safeguards which were introduced under the Mental Capacity Act but not yet implemented. I'm also aware of concern within the sector that there hasn't been adequate or meaningful engagement with people with learning disabilities or autism, or sufficient time for them to be properly involved in decisions that directly affect their lives. So could I ask the Minister how the government intends to remedy this, and whether they have a plan of stakeholder engagement, particularly with groups led by people with learning disabilities and autism? My Lords, one area that particularly concerns me, and we've heard a lot about today, is the position of children and young people who too often are receiving poor quality care in unsuitable conditions. There's many things we could do, I think, at committee stage to increase to strengthen the position for children. I was profoundly moved by the family experience, which was put forward by the Noble Lady Bradley. I thank her for that. There is much else I'd like to say on implementation, but I've probably run out of time. But I welcome the collaborative style adopted by the Minister to improving this bill, and look forward to working with other noble lords on this vitally important and long overdue piece of legislation.
My Lords, this has been a fascinating debate, and I have to admit, having read many of the various reports sent by many of the organisations, including the excellent briefing from the House of Lords Library, I felt pretty well briefed. But having listened to the contributions of today, including some incredibly moving contributions from my noble friend Baroness Browning, my noble Baroness Lady Parminter, the noble Baroness Lady Keeley and noble Baroness Lady Ramsay, I realise there is so much more for all of us to learn. My Lords, from these benches, can I say that we welcome this bill? And in particular, can I pay tribute to my noble friend Lady May, who as Prime Minister commissioned the Westley Review to consider a number of issues. As we have heard from many noble lords, why rates of detention were increasing, and in particular, what could be done to reduce inappropriate detention, understanding the point that the noble Baroness Lady Parmenter made very well about inappropriate, where detention may be appropriate and inappropriate, but also how to improve the way different agencies respond to people in crisis, to ensure that they are treated with dignity and respect. Also, to look at the disproportionate number of people from certain ethnic backgrounds, in fact, specifically Afro-Caribbean men, being detained under the Act, and what should be done about it. I am also grateful to noble lords who served as members of the Pre-Legislative Joint Committee for the 2022 Mental Health Bill, or Draft Mental Health Bill, which was obviously based on the recommendations of Sir Simon Westley's committee. Now, some of them have spoken in this debate tonight, in particular my noble friend Lady Buscombe, who chaired the Joint Committee, my noble friend Lady Berridge, the Noble Baroness Lady Hollins, who has a long history in this area from personal and professional experience. The Noble Baroness Lady Barker, who as many times says, "I've told you so." The Noble Lord Bradley, who was a champion for mental health during the Health and Care Bill, and despite lots of quite often resist him. I was urged to resist some of his amendments, but with hindsight, I'm glad he prevailed, in ensuring that we continued to discuss the parity between mental health and physical health. As many noble lords have said, the challenge is it's not how do we turn those words into action throughout the system. And can I also thank the Noble Baroness Lady Neuberger, who sat on the Wesley Review, and when we looked at this, when I was the Minister, gave me quite a bit of time to discuss this, partly I think because she chairs the trust of the hospital where I was born. They all had very incisive insights, and so in approaching this debate with my noble friend Lord Howe, we considered really the report from the Joint Committee, and this is what's generated many of our questions. And we wish to probe the government on the recommendations from the report, especially those that the government, the draft bill seems to disagree with. Not at this stage to tell the government where we agree or disagree, but more to understand the government's reasoning for not including specific recommendations from the Joint Committee. But also to ask the question, if and when this bill is passed, what next? How and when will the government implement the main changes in this bill, as the Noble Baroness Lady Murphy and Noble Lord Scriven alluded to? Last week, during oral questions, one of the Noble Minister Lady Merrin's ministerial colleagues made what sounded like a government commitment. But when questioned by one of my noble friends, the Noble Lady the Minister admitted that it was not a commitment, but an aspiration. Similarly, the briefing notes accompanying this year's King's speech stated that the bill would take a number of years to implement, and the government would introduce these reforms in phases as resources allow. So therefore, at this stage, we would like to understand which changes the government plans to introduce immediately and which reforms they are aspiring to rather than actively planning, and to make sure that we avoid some of the problems that the noble Lord Alderdice alluded to in his contribution. So now to the main areas which have been raised in today's debate, in which we would like to learn more about the government's intentions. The noble Lord Tuig reminded the House that autism is not a mental health condition, and my noble friend Lady Browning highlighted the lack of understanding of people with autism. And the Joint Committee recognised the risk that people with autism or learning disability could be given additional and unnecessary mental health diagnosis in an attempt to try to justify detention when they can no longer be detained under Part 2 of the Act. So can I ask the Noble Lady the Minister what firm plans the government has, whether in this bill or otherwise, to try and manage and mitigate this particular risk? On community treatment orders, the Joint Committee recommended the full statutory review of the use of community treatment orders within 3 years. But as my noble friend Lord Howe pointed out, there is no commitment to such a review on the face of the bill. So can the Noble Lady the Minister explain the government's reasoning to not committing to a review within 3 years? On children, both the Independent Review and the Joint Committee made recommendations, some of which are not in the bill, about the treatment of children, such as the inappropriate placement of under-18s into adult wards, or into facilities which may be miles away from their home. So can the Noble Lady the Minister clarify the government's position on these two specific issues, placing under-18s in adult wards, but also placing them in facilities far away from their homes? On advanced care documents, which the Noble Baroness Lady Barker has championed for many years, the Joint Committee recommended that these be made a statutory right for all patients detained under the Mental Health Act. But as my noble friend Lady Bascom has said, this could be done in the form of an app, if we make sure that we push through the digitisation of the NHS and the whole care system. But the bill as it stands does not follow up on this recommendation, preferring to place a duty, as I think one noble lord alluded to it being vague, a duty on NHS England and ICBs to inform patients about advanced care documents. Now, many noble lords, including Noble Lord Stevens, have raised this issue, so I think noble lords would find it helpful if the Noble Lady the Minister could explain the government's reasoning behind not introducing these documents as a statutory right in this bill. Now, on the role of police, My Lords, we welcome the bill removing police stations and prisons as places of safety for patients not in the criminal system. But as my noble friend Lord Howe said, one unintended consequence raised by several bodies was that this could lead to a rise in the number of people being admitted to A&E departments, sometimes escorted by police and having to wait in crowded spaces, with a lack of specialised facilities until they can be assessed by clinicians. So can I ask the Noble Lady Minister, when does the government envisage the NHS Trust will be able to deal with a potential increase in the number of mental health patients being admitted to hospitals as places of safety? Now, in addition, the President of the Royal College of Psychiatrists, who contributed to the independent review, raised concerns about proposed changes to the treatment of those with learning disabilities or autism, because there may be times when community services cannot manage the level of risk that such patients present, and when it might take some time to decide whether this is related to co-occurring mental illness. In such cases, patients may be brought into A&E. But what happens if their behaviour is perceived as affecting the safety of others in the A&E department? And this could lead to the police being called, and suddenly they're in the criminal justice system. So I wonder how the Noble Lady the Minister sees the proposed bill dealing with such a situation. Can I now turn to the issue of early intervention, which the British Association of Social Workers raised during the pre-legislative scrutiny, and the Noble Baroness Lady Watkins raised today, stressing the importance of early intervention to prevent admission of mental health patients into hospitals in the first place, which they described as being at the interface of the mental health and mental capacity legislation. Now, a number of noble lords have talked about whether we could have gone back to sort of from first principles and started with the fusion legislation, and we note that Sir Simon Westley suggested that this was not practical or it would take too much time. I wish not to misquote him. My noble friend, Lady Berridge, also mentioned the interface with the Children's Act. So it just shows that how can we do this in a holistic way? But by taking a step back, are we just waiting even longer for something to be done to fix the problems with the existing legislation? We have obviously decided this route, but I think one of the questions I would like to ask the noble lady, the noble Baroness Minister, is what thought is being given to perhaps future fusion legislation or rethinking the interface between the various acts affected here. Now, the Pre-Legislative Scrutiny Committee also recommended the creation of a mental health commissioner to oversee the direction of travel and the implementation, to monitor outcomes and support cultural change, to be an advocate for patients, their families and carers, and to speak up about the stigma still attached to severe mental illness. Yet the government has decided not to accept this recommendation, and I note a number of noble lords across the House have spoken on this missing part of the legislation. So could the noble lady the Minister explain why the role of the creation of a mental health commissioner has not found its way into this bill? Now, one of the main reasons for commissioning the independent review was to examine why so many people of Afro-Caribbean heritage are detained under the Mental Health Act. Indeed, Sir Simon Westley, in his report, wrote that one of his earliest academic papers in 1989 was on the subject of overrepresentation of those of black, African and Caribbean heritage amongst those diagnosed with schizophrenia. So can I ask the noble lady the Minister if the government, the NHS and the department are any closer to understanding the key factors behind this overrepresentation and what they can believe can be done to reduce the disparity, or does it need further research? The noble lady minister might find this odd coming from me, given when I was minister, I quite often tried to shield the government from this, but being asked by a workforce plan, now that the roles are reversed here, there might be a certain irony on this. And in all honesty, when we were in government, we were pressured by the Treasury not to accept this and quite often pushed back, even when we tried to make the case for this. So I understand it's a real challenge for the government. I think we completely understand, and it would be unfair of me now to sort of take advantage of the fact that I'm in opposition. So I do wonder about our government belatedly published a workforce plan. What is the thinking of publishing a workforce plan, given that many noble lords across the House have asked about this, particularly once the bill becomes an act? And how long will it take to actually implement this? We really need to understand more about the resources. Otherwise, it could make things worse. I realise that I and other noble lords have many questions, and I certainly do not envy the Noble Lady the Minister. But can I just say we look forward to the Noble Lady Minister's responses either now or in writing, and we welcome her engagement with Noble Lords across the House.
Well, my Lords, let me start by putting on record my gratitude to all members of your Lordship's House who have contributed to what is widely agreed, I'm sure, to have been an excellent debate. Excellent not just because of the level engagement, but because of the detail, and because I really feel that spirit of wanting to improve the legislation and also the support for the bill thus far. I will endeavour to respond to as many themes as possible. I'm very grateful to the Noble Lord, Lord Kamal, for his sympathy, which I accept. But I regard that as a good thing. I regard it as admirable that I will not be able to answer all of the questions, because that is the purpose of being here. And also it sets us up, I believe, for committee stage. And that's obviously going to be a very rich committee stage, and I very much look forward to it. So I hope that Noble Lords will understand that for those many points which I won't get a chance to address in the time that I've got, that I will be looking forward to following up and indeed doing a proper review of the debate today and picking up points as are needed to. And I want to pay tribute to the dedication and the detailed attention to this bill that Noble Lords have already given. And I'm very glad to see my right honourable friend, the Secretary of State, gazing on. And the reason I say it at that point is because the Secretary of State knows only too well, and not just from me, the contribution that your Lordship's House makes and will continue to do. And I, for one, certainly appreciate it, as I know that he does. I also want to thank the Noble Lady Baroness Parminter for her bravery of sharing her and her family's experience and anguish of eating disorder. And I say the same to my noble friend who also shared her experience about her sibling. It isn't easy always to do that, but it really brings a lived experience of those around the person we're often thinking about, and it's so important that we do that. So, my Lords, this debate has confirmed to me what I knew already, but it's always worth doing it again. It is the product, I believe, of persistent, of a number of investigations and recommendations, and is also inspired and underwritten by the tireless campaigning that many have undertaken to improve the rights and experience of people with mental health conditions, learning disabilities and autistic people. And it also reflects the input of those with lived experience, and that's something that was first raised as necessary in this debate by the Noble Lady Baroness May. And it is about striking the right balance here between getting the details right of a framework of legislation along with the urgent need for a reform and the whole point which Noble Lords have raised about how is this going to be done. My Lords, attitudes and knowledge, as many Noble Lords have acknowledged, have changed radically. Mental health is increasingly out of the shadows, and through this bill we can make sure that legislation does a much better job of keeping up with a shift in societal attitudes, expectations, and the development of treatment. And to the role of your Lordship's House, I, like the Noble Ladies Baroness May and Baroness Barker, also recognise the relevance of your Lordship's House. And I too very much welcome the fact that the bill has started its passage through Parliament here, because I believe that your Lordship's House will do the job it's always here to do, which is to improve legislation, and this debate today has certainly confirmed that. And if we are looking at what we are trying to achieve, I'm reminded of the words of Professor Sir Simon Wesley in his foreword to the Independent Review's final report, where he said, "We want the Mental Health Act to work better for patients, the public and professionals. We hope that the result will be to reduce the use of coercion across the system, whilst also giving service users more choice, more control and better care, even in the event that detention is still required. And we particularly hope that the end result will be to reduce the inequalities and discrimination that still remain." My Lords, almost 6 years later, from when the former Prime Minister, the Noble Lady Baroness May, commissioned that report, that independent review, the draft legislation before us does speak to those aspirations and also delivers our manifesto commitment to modernise the 1983 Act. I do want to refer to the matter of reduction of detentions, and I certainly agree with the Noble Lady Baroness Murphy and other noble lords that reducing detentions cannot be achieved by legislation alone, and it will depend on having the right services in the community. New models of care in the NHS are already giving over 400,000 adults greater choice and control over their care, and we're also now trialling new models of care through 6 early implementers, bringing together community, crisis and inpatient functions into one neighbourhood team, and that will be available 24 hours a day, 7 days a week, to increase access and also improve continuity of care in the community. And I know from this debate today that many noble lords are looking for that sort of development and good practice. So, as we know, the bill does make a number of improvements in respect of patient experiences and care, and also about the increase of choice and autonomy. It seeks to tackle racial discrimination and provide safety for public, staff and also for patients, and to provide better support for those with autism and learning disabilities. So to now turn to some of the main themes that have been raised, and I would first of all like to say to the Noble Lady Baroness Taylor how we are continued to be committed to engaging with those with lived experience, because part of the point about this bill is that those with lived experience have not had their voices heard, and I believe that our continued engagement will allow that. To racial inequalities, first of all, many have spoken passionately about this matter, including the Noble Lady Baroness Watkins, Baroness Buscombe and the Noble Lord Adebowale. And the racial disparities associated with the operation of the current Act is, of course, one of the many drivers of reform, and rightly so, because the changes in this bill will give patients greater say in their treatment, encourage more collaboration and less coercion in care and treatment planning, and they're all crucial to reducing inequalities. And this will include increasing oversight and scrutiny of community treatment orders, where racial inequalities are at their most acute. And it will also be about encouraging the uptake of advanced choice documents, where those with lived experience, as I said in my opening remarks, have been very generous in their reference to their use in reducing inequalities, whilst also legislating so that people can choose their own nominated person, will also protect rights. But inequalities and outcomes are not just a result of how the Act has been applied, but also due to wider social and economic factors, and we'll therefore be working across government to ensure that the bill's provisions are effectively implemented, aiming to reduce those racial disparities in decision-making under the Act, starting with using the Code of Practice to make clear actions that can be taken in the application of the Act. And we are also taking forward non-legislative reforms recommended by the independent review, including the Patient and Carer Race Equality Network framework, and also piloting culturally appropriate advocacy models to support those from minority ethnic backgrounds to understand their rights under the Mental Health Act, and also to give voice to their individual needs. On the Mental Health Commissioner, I have heard much comment, including those expressed by the noble ladies Baroness Murphy, Baroness Barker, Baroness Buscombe, Baroness Berridge, and the noble Lord Bradley and others, and that's quite a group to address, but I'll have a go. So it is true that we have not taken forward the pre-leg scrutiny committee's recommendation to establish a statutory mental health commissioner, and we do recognise that improvements do need to be made to the quality of care and patient safety landscape. However, the concerns are that the proposed mental health commissioner's function would be potentially largely duplicative of existing bodies and functions, and nobody wants to risk diluting accountability or causing confusion. And of course, as noble lords will know, Dr. Penny Dash has been asked by the Secretary of State to assess if the current range and combination of organisations within the healthcare and regulation landscape is effective, and to make recommendations on what might be needed. And I do think it's important that we do await her recommendations. On learning disability and autism, raised by a number of noble lords, in particular by the noble lady Baroness Hollins, Baroness Buscombe, Baroness Browning, Baroness Keeley, Baroness Ramsay, and noble lords Lord Tuig, Lord Scriven and Lord Adebowale. This is a really important point, and I absolutely recognise that we want to improve care and support for the over 2,000 people who are currently detained, as well as anybody who may need support in the future. And we know from the NHS's safe and wellbeing reviews that 4 in 10 people who are detained in this group had needs which could have been met in the community with appropriate support. And so that is why we're going to be focusing on developing community services and improving the quality of care, which will happen alongside the bill's reforms. And through the bill, we will be taking forward a package of measures for those with a learning disability and autistic people. So there will be a significant programme of work alongside investment, and I will be pleased to be engaging with expert stakeholders, those with lived experience, with parliamentarians, and I will be pleased to update your Lordship's House as we move through. With regard to the recommendations of the Pre-Legislative Scrutiny Committee, there's no doubt in my mind that this bill has benefited greatly from undergoing scrutiny in 2022. It is a better bill for that, and we have tried to incorporate more of the Joint Committee's recommendations within the bill. What I would say is that many of the Joint Committee's recommendations relate to the statutory code of practice, and we will consider how we take these forward following royal assent. To the important point of implementation, raised by many noble lords, including Lord Adebowale and Lord Bradley. The truth is that we estimate that the full implementation of these reforms will take around 10 years, and the speed at which we can implement is going to be limited by the time we need to expand and train the workforce, to the point raised by the noble Lord, Lord Kamal. And I'm grateful for his honesty in the way he described previous work on the workforce, and thank him and his colleagues, ministerial colleagues, predecessors of mine who have worked on this. But the reality is that whilst some reforms can commence much sooner on others, of course we need to be commencing powers in the new bill in phases, and implementation will depend on what happens during the passage of the bill. And the reality is, and to the noble Lord Stevens' point, future funding settlements, as well as other developments such as the 10-year plan. But I can briefly give an indicative timeline, which is that a small number of reforms relating to the criminal justice elements of the bill will commence within 2 months of royal assent. In the first year after royal assent, there will be a focus on updating the code of practice and creating the necessary secondary legislation to enable implementation. We will need a further year to train existing staff on the reforms, ensure that processes are in place, and we would therefore hope to commence the first phase of significant reform in 2027 and commence further reforms as and when there is sufficient resource in place to do so. And in a spirit of honesty, the truth is that with what I would call the most burdensome reforms, for example, the increased frequency of mental health tribunals, would not be likely to commence before 2031-32. And alongside the passage of the bill itself, we're also looking closely at implementation in relation to learning disability and autism. And again, the exact timing of implementation of the reforms will depend on future funding. I know that noble lords will understand that I'm limited about what I can say to that, but I would say we have already demonstrated our mode or direction of travel to treating and resourcing mental health seriously, including a mental health professional in every school, introducing open access youth future hubs, recruiting 8,500 mental health workers, and 26 million in capital investment. And indeed, the priority that many noble lords have acknowledged, in that, including the noble Lord Crisp, of actually bringing this bill forward as a matter of priority. The noble Lord Meston, the noble Lady Baroness Berridge, raised about the disparity of treatment between children and adults. And it is true there are a small number of reforms which do not apply to children and young people, something also raised by the noble Lady Baroness Watkins, but that is the case, that there is a difference. But we are nevertheless committed to improving children and young people's autonomy over their care and treatment, and we do still believe that these reforms will go some way to achieving this. And like adults, under 18 should be supported to share their wishes and feelings by their clinician when it comes to care and to treatment decisions. In respect of prison transfers, which was raised by the noble Lady Baroness Watkins, the noble Lord Scriven, the noble Lord Bradley, and the noble Lord Adebowale, we do recognise that operational improvements are needed to ensure the safe and effective implementation of the statutory 28-day limit. And NHS England are indeed taking steps to address some of the barriers to timely transfer of patients. and the wording in the bill to seek to ensure a transfer within 28 days should be sufficiently robust to provide accountability for a breach of that time limit, whilst recognising that there are multiple agencies who are actually involved. My Lords, as we know, whilst this legislation does improve...
Order. I hate to interrupt at the lateness of the day and the lateness of the hour, but the point I believe that a number of noble lords was making in relation to children is that this Act is potentially not sitting with the Children Act and the principles under the Children Act. If the government is intending to impliedly repeal parts of the Children Act, then it would be good to have that clarification from the dispatch box.
Well, I look forward to coming to that point when we are in committee stage, but to say that the marrying up of legislation is going to be important, but as is also making progress in respect of the mental health bill, and that applies to Lord Alderdice's point also about, and other noble lords, about fusion. The point is we do not want to hold up this bill while we make progress, but yes, indeed, we will be mindful of the interface with other legislation. So, my Lords, in this bill, we are starting with the most overdue reforms to make the law fit for the 21st century. I very much look forward to working through the bill in much greater detail at committee stage, and I'm most grateful to all noble lords who've not just spoken this evening, but for their work to get us to this point. My Lords, I beg to move.
The question is that this bill be now read a second time. As many as are of that opinion will say content. Contrary not content, the contents have it.
My Lords, I beg to move the other motions standing in my name on the order paper.
The question is this motion be agreed to. As many as are of that opinion will say content. Contrary not content, the contents have it.
My Lords, I beg to move that this House do now adjourn.
That the House do now adjourn.